Bismillah ar-Rahman ar-Rahim. We will start our conference. Ladies and gentlemen, welcome to the second and multi-speciality conference between Somaliland and Taiwan, hosted by Taiwan and Wanfang Hospital and Hersi Group Hospital. And and our conference first, we will start with the Quran and read by Abdullah.
بسم الله الرحمن الرحيم أرأيت الذي يكذب بالدين فذلك الذي يدعو اليتيم ولا يحض على طعام المسكين فويل للمصلين الذين هم عن صلاتهم زاهون الذين هم يراءون ويمنعون الماعون صدق الله العظيم.
Thank you, Abdillahi. And first, we will welcome our guests all the way from Taiwan to participate this conference, and all doctors. And Dr. Tex will give us the first remarks to call the opening.
Please welcome our remark. First is our from Wanfang Hospital, our Taiwan Medical Mission, our headquarters, our superintendent, Dr. Liu, please.
Vice Director Dr. Anam, and the Vice Superintendent Professor Zhang, and Dr. Tex Li, and my dear colleague from Taiwan medical team and the Wanfang Hospital, my all good friends in Somaliland, and the ladies and gentlemen, good morning. I'm Dr. Chen Liu from Taiwan, Taipei Wanfang Hospital. It's truly a great pleasure for me to be here to see all of you today. In the past 2 years, Wanfang Hospital have been sending several medical teams to come this beautiful country, Somaliland, in various fields. And we have completed several and a lot of medical missions cooperation in Hersi Group Hospital in various fields, including orthopedics, anesthesia, infectious disease, oral surgery, and nursing. And I'm happy this year we are honored to receive a Hersi Group Hospital sending their professionals to Taiwan this year, and for exchanging our and training in Taiwan. And I extend my great appreciation to all of you to participate in this conference. And your presence here today signifies our shared commitment to advancing medical knowledge and improving the healthcare delivery. I wish all of you enjoy today's conference seminar and have a nice day. Thank you.
Thank you for Professor Liu. And we have the other very wonderful, very famous, our in hospital, our Deputy Director, Dr. Adnan. Welcome.
Assalamu alaikum wa rahmatullah. Subah wanaagsan. Subah wanaagsan. Dr. Liu, sorry if I can't say the words, the names in a proper way, but I will try my best to tell you names. Yeah. Dr. Liu, Dr. Chen, and another Dr. Yubin, Dr. Chen, Rocha, dear doctors, dear colleagues, distinguished guests from Taiwan, and colleagues from Hersi Group Hospital, welcome to this conference. This is the second time we have this kind of conference in Somaliland. This shows the collaboration, the partnership, and the commitment we have from both Somaliland and from Taiwan government to advance our collaboration in knowledge sharing and skill transfer, and also contributing to each other in aspects of health system development. So we are very thankful for the visit that you have made to Somaliland, and we are really grateful the support that you already provided to Hargeisa Group Hospital, and we are expecting a lot to come in this partnership. Thank you very much. Let me say little words in Somali. Assalamu alaikum. Waan salaamaya dhammaantiin. Waxaa ahayd inaynu mar hore isku soo wada gaadhno. Habsan baa nagu yar jira dhakhaatiirtii ka socotay qaybteena. Laakiinse shirka insha Allah markuu dhexbartankii socdo baynu sira xasuusin doonaa. Shirkan wuxuu ku saabsan yahay in aqoonta ay halkan ku hayno iyo ta ay halkaa ku hayaan aynu isla isweydaarsano. Innaga ayaa dadka wax baranaya ah runta marka laga hadlayo iyagu waa dad aqoontoodii ay horu martay, laakiinse innaga ayaa wax ka baranayna. Fursado badan baa markaa sanadkan inoogu jira muxuu ahaa wada shaqaynta aan la shaqaynayno Taiwan Medical Mission. Fursadaas waxaa ugu horeeya in ay dhakhaatiir iyo shaqaale ka mid ah cusbitaalkeena tababar ay u tagaan muxuu ahaa Taiwan, kadibna insha Allah waxay ka soo bartaan ay ku dabaqaan Hargeysa iyo muxuu ahaa Somaliland iyo cusbitaalkeena. Waxaan rajaynayaa insha Allah in shirkana aynu ka wada qayb qaadano, ka faa'iideysano. Aad iyo aad baa u mahadsantihiin. Thank you very much, and the conference is officially open. Thank you.
Aad baad u mahadsantahay agaasime. Thank you, Dr. Adnan. And we will start our conference, and our first presenter is Dr. Tex, the Chief of Taiwan Medical Mission in Somaliland, and he will be talking about the dengue fever in Somaliland.
Thank you for Dr. Hassan introducing. I'm coming from Taiwan Medical Mission, the chief. I stay here for 2 years. So first I want to, for this special event for tomorrow, today is 11, so for the 12th is a World International Nurses Day. So for the special day for tomorrow, so yeah, but our conference is today. So we are with some beautiful good gift for all the participants, the nurses here. And then later when we finish our meeting, we can come together with a group photo. And also our Taiwan embassy, representative also come here later, around maybe 11. So please, I say our doctors will welcome and happy for nurses help us to working together to help our people right here. So thank you for you, very wonderful and appreciated for the giving and working for the patients. Mahasani. Thank you so much. Okay, Rakia, aye. Okay, so so return to our today's brief talking. Today we have 3 sections. The first section is talking about dengue fever. Dengue fever is an issue, is a problem. But for Taiwan, we have many experience because Taiwan is more hot than here during the whole season. So we have more mosquito, and we also have more some of the imported patients from surrounding country. So annually, we will with a similar situation. From the beginning around now, going to the summer, and the case was increasing. And finally this reduction until finish at the winter. Because mosquito cannot survive a longer time, lifetime, during his life in the cooler weather. Temperature. The temperature should be maybe below to 26 degrees Celsius, and mosquito with a shorter life. So that means when he got infected by dengue virus to him, the mosquito, but he doesn't have the good enough the time to generate the virus going to his saliva, mouth, and then go to bite the other human to transmission the virus. So the temperature is a very important issue. So this is why every year, annually, going the winter, the mosquito will disappear. Yeah, because his life is shorter. Okay, so, but for the human part, if the dengue virus the human was be bited first by the mosquito, of course, and the mosquito carrying the dengue virus in his saliva. So he will bite and injection virus and suck in the blood and fry. But we we will get some of the virus, dengue virus, going to our body. So that means, okay, if the patient, got the dengue virus infection through the mosquito, so all the virus infection from dengue, they will be self-limited. So that means I will recover by myself. But if unfortunately I go into the other situation, maybe I will die in some few of the percentage. So what we will do? So if we got a patient got a fever, so by the WHO definition, that's meaning if the patient is in this area with a possibility or with a previous case of the dengue fever, something like here, Hargeisa, or Gable, or Boroma. And then we live here and wake up. Yeah. And then if I got a fever, so first the situation is if I got a fever, and also it's a high fever, high like that, 40 degree, for a couple of days, and I live here in Hargeisa. I got a fever. And also, we have the other situation, abdominal pain, maybe vomiting or nausea, and sometimes the skin was rash, and the eye, behind my eye is painful, or maybe with something that my joint is pain, my muscle is pain. So all that other situation will say, okay, I was maybe probably the suspect case of dengue fever. So this is the first situation. We clinic working, we need to identify that. And then if clinic doctor, later on the Dr. Ahmed, NCD doctor will come here to teach us how to treat the dengue fever patient. But before that, all are working in hospital, we will know about this situation. And if we think this is maybe the dengue fever patient, and then we will call the Dr. Ahmed Kale to making some prescription, checking by laboratory for some of the protein in my body to check I'm the confirmed dengue fever patient. Okay, so this is briefly the concept for that. For dengue fever, relationship with human and the mosquito. Okay, and according to that, Dr. Ahmed will let us to try to classification the patients by different, by mild, in the severe or warning situation. That meaning if the patient with several kinds of very important symptom or sign, for example, abdominal pain, vomiting, but not only one day, maybe several days, maybe 1 day, 2 days, 3 days, 5 days, and maybe I have some fluid situation, the water not in the vascular, he go outside the lung, go outside of the abdomen. So I will be swelling or edema. Or maybe with some of the platelet situation is gradually down, low, easy to breathing. So this situation is to warning a clinical worker to say, okay, this dengue fever patient, he got trouble. So we need help then, admission then, giving good supporting until his recovery. Okay, so the classification for the ABC, for the dengue fever with a different criteria, different region, different classify is important. Most of the people will stay at home, leaving the patient with the mosquito net to pretension the mosquito bite again, to transmission virus to the other people, their neighborhood, their family. And also, he will stay home, resting with the acetaminophen for pain control, for fever control, more water, something like that. Okay, and then usually 1 week later, he will gradually recover. But, this belongs to type group A. But the case, the patient belongs to B or C with the following important problem to them. They will be, of course, they will gradually recover by themselves. But if we didn't support them, good support for them, for fluid, for the blood for platelet or maybe respiratory with some situation. If we don't admission ICU to support them in our hospital, they may be going to die. So good classification for the dengue fever patient is very important. We cannot preventing the dengue fever, the mosquito to go to bite the patient to get it transmitted. But with some vector control, maybe can do. Taiwan Experience, the next speaker will talk about that. But for us, right now, we need to know what the patient situation, which one will be intending go to the severe dengue and intending to risky for his life. And we will want to put them in our good observation in our ward and carried by our nurses to save their life until they recover. Okay, so this is a very, very important concept for that. Yes, okay. So overall, from the WHO, some of the information, they say, yes, since the 2022, there's a new event, new dengue fever starting in the Somaliland. And last year, before going to the winter, accumulation with some cases suspect with the dengue fever. And this case, some of them, just few of them, was be tested by laboratory to say, okay, they are confirmed the case. And for this, so that's meaning we need some laboratory, some kit to test our patient to classify as they have the which category, okay, and confirm the disease, dengue fever. Okay, and for this, the other important thing is the vector control. Vector meaning someone carrying the virus, dengue virus to our body, not the other man. This is a mosquito. So vector control is meant to control the vector between the human to transmission. That means the mosquito. We need to control them. We want to, they live in our life to protection us to get the dengue fever infection. Okay, there's many advanced situation, but usually in Taiwan will be some spreading the medicine, some agent, some chemical to killing them or repelling them, and some strategy for that. Okay, and the other most important, this is for the mosquito, but also important things that we some the monitoring. Now the group hospital with a good heat system from Taiwan, ICDF. And according to that, the data, all the OPD data, dengue fever case will be calculated. So we will know how the situation increasing the case by monthly, by weekly, until declined. Okay. And then we will, according to that, to arrangement our rapid tests, lab tests, to check in and confirm the case, and classify them as if going to severe dengue, go to admission. Rest of them, minor case, go home, live in the mosquito. Care by the family is enough. Okay, so, and for the WHO, they do some good situation to help in Somaliland. That means last year they found the case through the Somalia to reporting the headquarters in WHO, Switzerland. And then they submit something, the important test, rapid test, and also reporting that, statistic for that, counting the number. And also they offer the IEC material to teaching everybody, to general population to know how to avoid the mosquito, how to identify the dengue fever. It happened, okay? So it's that WHO help us to like that way. And also, so for furthermore, because for example, the UNICEF will also introduced by WHO to suggest them to do the vector control. That means do something, somehow, to make the mosquito less and avoid, to isolate from human. Okay, so we will always remember, dengue fever disease is the virus, dengue virus, but he need to be mosquito to transmit it as a vector from one human to the other human. Okay, so we will multiple factor to control that. Not only for treatment human only, it's not good enough. Okay. So before the Mahasani, also we will thank you for the East Mediterranean region of the WHO office. That means from the East, from the Arabic world and around here, East Africa. So all that with some statistic and supporting surveillance and some strategy for that. So yeah, now we'll end for my speech around here. It's just a briefly introducing for dengue fever because he's coming in our country here, in Somaliland here. Okay, so Mahasani, thank you so much.
My name is Chen. I'm a neurologist from Taipei Medical University Wanfang Hospital, and I'm also the director of business development. My department in charge of the international affairs, so that's the reason why I come here. Today I'm going to talk about our Taiwan experience regarding dengue fever, and this beautiful picture actually generated by AI. We call Gamma. It's free. This is we call Taipei 101 building. It's the second highest building in Taipei, in the world. Dr. Chi, could you adjust? Sorry. Okay, thank you. First of all, I will talk about the backgrounds. We know the dengue fever is a viral infection caused by the dengue virus, Dengue. Half of the world's population is now at risk of dengue. Every year we have 1 to 400 million infections all over the world. And dengue is found in tropical and the subtropical area, mostly between latitudes 35 degree north and 35 degree south. And actually, right now we have more than 100 countries report the dengue outbreaks. And this is a global map of dengue risk by US CDC. You can see Somaliland is here and Taiwan is here. We are in the same boat, all in the frequent and the continued dengue risk area. And talk about the global burden and the impact. During past 50 years, the worldwide incidence of dengue has risen 30 times. And the economic burden of the dengue is around 8.9 billion US dollars annually. And the incidence of the dengue has increased dramatically because of urbanization, global warming, and increased global travel and trade. And we know dengue is the most important mosquito-borne viral disease in the world. In Taiwan, we have 130 different kinds of mosquitoes. But the dengue fever is transmitted to humans mostly through the Aedes mosquitoes, especially the Aedes aegypti and the Aedes albopictus, those two mosquitoes. And this is a distribution of the two kinds of mosquitoes in Taiwan. The green spots is the Aedes albopictus. You can see it spread all over the Taiwan except the central mountain area. And the red spots is the Aedes aegypti, only in the southern Taiwan, except Taipei city, which is the place we come from, because we have many imported foreign family caregiver. So we have a red spot here. And this is the dengue fever map in Taiwan. You can see the most of the cases happen in the southern Taiwan. So compared to the mosquito distribution map, you can see the Aedes aegypti is the major vector in Taiwan. And we have several outbreaks in Taiwan since 1988 and 2006 and 2015. We have large outbreaks. In fact, more than 43,000 cases and 228 deaths. So the mortality rate is around 0.5%. And since the COVID pandemic, we have 3 years border closing. So it's a good thing because the dengue infection number is remarkably decreased. However, after the COVID pandemic, since 2023, we have more international and domestic exchange from the neighbor countries, and the weather, because of global warming, is getting hotter and humid. So we have more cases. For 2023, we have another outbreak. And this is in indigenous dengue cases in Taiwan from 1987 to 2023. You can see the several outbreaks I just talked about. And the 2015 dengue outbreak is very scary at that time. You can see this is the emergency room in Tainan City. We use the mosquito nets in the emergency room to protect the patients. And we know the dengue virus has 4 known serotypes, dengue 1, 2, 3, and 4. In northern Taiwan, we have dengue 1 and 2. But in southern Taiwan, we have all 4 types of serotypes of dengue virus. And right now, Taiwan has 750,000 foreign workers, mostly from Southeastern Asia. It's also a dengue hot zone. So every year we have the imported dengue cases. That's why the border control is also very important for us. And this is the COVID years. The factors of the occurrence of dengue fever in Taiwan, because of I just talked about the global warming, the climate change, urbanization. People all goes from the suburban area to the big cities. And we have a lot of international travel and the trades. The clinical symptom, I would not talk too much because Dr. Chi already talked about it. Fever, severe headache, we call it splitting headache. And you have very severe muscle and joint pain, we call breakbone fever. And you can have a specific maculopapular rashes. And this is a flowchart of classification of dengue infection. The most important part is to differentiate the severe dengue, include dengue hemorrhagic fever and the dengue shock syndrome. And this is the clinical symptoms of the dengue infection. I will not talk too much about this. So the most severe dengue I just told is a dengue hemorrhagic fever, a dengue shock syndrome. Actually, the number is not so much. I remember it's less than 10%. But the 10% of the case is the major cause of hospital admission, and the mortality in the, especially the mortality in children. If untreated, the mortality rate of severe dengue can go high as 20%. However, if you can differentiate early the severe dengue cases and give them appropriate medical treatment, the mortality rate can be reduced to this 1%. So in Taiwan, our mortality rate is around, I just say, 0.5%. And the most important part of the dengue hemorrhagic fever is the plasma leakage, bleeding, and the liver impairment, especially the liver. And that's the risk factors of the severe dengue, including the epidemiological factors, the virus risk factors, biotic risk factors, and the human risk factors. And about the diagnosis and testing, we can use the laboratory test to do the serological assay and the molecular test. And for blood test, we can do the to check the specific dengue IgG and the IgM. We can also use the microscopic examination to differentiate the dengue serotype. And one very important issue is the timing of tests. I will talk about it later. The laboratory test, NS1 rapid test is the most popular one. In Taiwan, many clinics has the free NS1 rapid test prepared by the government. If the patient go to the clinic under the certain, if they fit the criteria, we can do the test for them. And the doctors need to report to the government within 24 hours. And other serological tests include the ELISA to check the IgG and the IgM antibody. And we can also use the PCR test. In Taiwan, we can make our own dengue NS1 rapid test. You can see the results within 1 hour. The timing of the testing is very important. The PCR is for only the first week to do the acute test. And after the first week, the serological test, we can see the IgG and the IgM. And the Taiwan CDC recommend a combination of the test to ensure the accuracy of the diagnosis. The treatment and the management, we know there is no antivirus agent right now for dengue fever. So the treatment mostly is the supportive care. And for severe dengue, you need hospitalization. So early detection and good medical care is very crucial. There are two kinds of dengue vaccine right now in the world. More is coming. The most early one is what we call the Dengue, made by Sanofi pharmacy company. You need 3 injections within 1 year. And the United States, FDA, and the Europe, they already approved the vaccine in the individuals, but aged between the 9 to 45 years old. But the Dengue actually has very limited use because of you need to use in the patient already have the dengue infection. The color shows the severity of disease. In the natural situation, unvaccinated individual, you have first dengue infection, the symptom may be very mild, but second infection can be very, very bad. If you use the vaccine in the, we call the dengue naive case, if the patient got their dengue infection after the vaccination, they will have very difficult situation of the infection. So the vaccine can only use in the patient already have the dengue infection. Then you vaccinated them, and then they got the protection effect. So you need to use the vaccine in the in the area already have a dengue infection, or you need to check the patient's IgG before using the vaccine. So it's not very popular for this vaccine now. And second vaccine is made by Japan, Dengue. Taiwan has already finished the clinical trial, but now this vaccine can use in the patients without previous infection. Now already approved in the EU, Europe, UK, Brazil, Argentina, Indonesia, and Thailand, but not in the United States and Taiwan. So in Taiwan, we don't use any dengue vaccine now. And so the most important part is the prevention. Taiwan CDC recommended 3 steps of the prevention measures. For the primary prevention measures include health education, and through various communication channels, include TV, include the internet. And we can encourage to eliminate the vector breeding source, and especially you need to keep a record to do the future inspection. And you need to strengthen the education and the training to do for the prevention workers and the volunteers. So community is very important. And you also need to do the vector surveillance mechanism. You can see from the YouTube, Taiwan CDC made this video, education video. You can see it online. And we also use the poster to mention the 6 common hideouts of the mosquitoes, like a water container, the solid waste, the natural containers, and some plant, especially house plant, and to check the basement. Some basement can contain waters inside. And you need to check your roof drain pipes. That's the community volunteers help to remove the expired tires to remove it, because this inside can contain waters. And in Taiwan, we have Taiwan people like to have their house plant in their house. But the water in the container is the problem. So we encourage people can use we call guppy fish and the betta fish, 2 kinds of small fish. They like to eat mosquito larvae. And the secondary prevention measures include the disease surveillance mechanism and the set up emergency and contingency mechanisms. And this is the dengue mosquito monitor system in Tainan City. Include the breakthrough index, include the adult index, include the housing index, and the container index. And the government will renew it regularly to monitor the mosquitoes. And we also use pesticide spraying, and this is actually their army. We use some army individuals to help us to do the pesticide spraying. And we also use some insect repellent like a DEET, Picatinny, and the IR 3535 to do the personal protection from mosquito bite. The tertiary prevention measures include establishing guideline to control the mortality rate. And the education workshop that we are doing here is very important for medical personnel to raise the health care quality and lower the mortality rates. And this is the education sheet made by Taiwan CDC. This is the English edition, and this is the Chinese edition. Help people to differentiate the general symptom or the severe dengue symptom. And we also published the clinical guideline for dengue fevers. Actually, you can download it from the internet, but it's all, of course, it's all Chinese. And we have many imported cases, so the border control is very important. So we have a screening in the airport to do the international migrant workers monitor. You can see we do a lot of tests, and the red line shows the positive rate. And for the education sheet, we have different language for the foreign visitors. We have Indonesian edition, we have Vietnam edition, we have Thailand edition, and I just say English edition. And we also do a lot of research. From the mainline, we can find around 1,000 articles since 1967 to now. And this is my last slides. The challenge and effort in Taiwan is the vector control, the public education of the awareness, and the surveillance system is very important. Hopefully, we can do some connection with Somaliland. Thank you for your listening.
Thank you, Professor. Now there will be panel discussion on Dr. Adnan, Dr. Tex, and Dr. Chen. So, if you have something on that, come.
I think we need first-hand information from Dr. Adnan for this hospital for past 1 year, how the situation.
Thank you, doctors. Thank you, everyone. I think it was first time to hear dengue fever in Somaliland was 2022. Before that, we used to hear. I saw the map you have shown a little bit ago, which has shown that there was Somaliland and Taiwan has the same color regarding the epidemiology and the incidence of dengue fever in Taiwan and Somaliland. So we were more or less similar, but in reality and in our context, we it was the first time we have an epidemic outbreak of dengue fever in 2022. So that information is a little bit seems inconsistent to what we used to have in Somaliland. But currently, what we have seen is that the number of outbreaks is increasing in Somaliland with different with different causes. For example, in 2019 and 2020, we had the COVID-19, and before that we already had a measles outbreak, and in 2022 we had also this dengue outbreak, and currently there is a risk of acute watery diarrhea outbreak to take place in Somaliland, where several cases has been reported so far from Burco region and also from Gibley and also in Mogadishu region, which is the capital city of Somaliland. So there's a lot we have learned so far from how to deal with outbreaks. The most important thing that we have learned so far is that the prevention and cutting and breaking the transmission cause is what matters during the outbreaks. So we think with your collaboration and with the learning experience that you already have, we think Hargeisa and also Minister of Health of Somaliland can learn and look how we can get ready for any outbreak to take place in the coming years, which is possibly inevitable. We cannot. We know that this climate change and that increased people trafficking and the less the border control system in Somalia, which is not that strong and sufficient, there will be a lot of outbreaks or a lot of transported cases or infections can reach Somaliland. So in Hargeisa Group Hospital, we have managed it, as Dr. Tegas showed you, a lot of numbers in 2022, but most of cases at the first beginning of the outbreak, they were so severe, and the mortality compared to the number of cases we received was kind of mild, not that much, but it was higher than the mortality we had last year, because last year it was like the public awareness and patient education has been increased, and most of the cases were mild, and the preventive measures that has been taken was also good. And Minister of Health and doctors in Somaliland, particularly those who are involved in medical management and internal medicine specialists, have worked a lot to distribute the information and to share publicly how to prevent dengue fever to occur. And nowadays there is in the Ministry of Health, as far as I know, there is a commission or a department concerning control of dengue fever and also vector-borne disease. So they are also providing mosquito nets. Also, they are doing some mass, mosquito, prevention and eradication campaigns. So thank you very much. Thank you for presenting the information. But what is also surprising and also makes sense for us is the vaccination, which we don't see as the evidence now shown. There is no benefit of vaccination so far, and the current vaccinations cannot prevent, in most of the cases, they cannot prevent dengue fever infection to occur, or to at least reduce the complications that result from dengue fever infection. But what we can see is that sometimes it's much worse than you had an infection and then you get a vaccination, and the infection is much more severe, and complications are much more worse than getting the infection in the primary or the firstborn. Thank you very much. Thank you a lot.
Thank you, Dr. Anand, for your response to the two presentations. I think it's an important issue. I guess that in the past you may not see lots of the dengue fever cases in part, perhaps because there's under-detection of infection. Because the majority of patients infected would be asymptomatic or have only mild symptoms. So they would not bother themselves to come forward to a hospital. But only a fraction of those patients, they would have severe symptoms, they may come forward. So what you would have seen would likely be just the tip of the iceberg of the epidemic. So unless you test, without that information, it would be very difficult to decide who will benefit from vaccination. Because those who have not yet been infected, they would be at high risk of severe symptoms if they are really infected. Because the severe symptoms, the dengue shock syndromes, dengue hemorrhagic fevers, many occur among those who've been infected with different serotype of the virus, because there are 4 major types of virus. So if be infected with type 1, and then reinfected with type 2 or type 3 or type 4, then you're at high risk of severe symptom and mortality, 50%. So that is the, I think, the important thing to keep in mind, number one. Number two is that the proportion of people die in an epidemic was 1%, 2%, sometimes 0.5%. That's what we have seen in Taiwan. And so it depends on your perspective about what does 1% mean. So 1% is 1 in 100. Would that be high or low? It depends on your perspective. So think about tuberculosis. How many people would die from tuberculosis? Is it more than 1% or less than 1%? Is it less than 1%? Is it less than 1%? So meaning that it's something that perhaps we can keep in mind. And then second is that for the dengue fever, it mainly comes from mosquito. It's mainly come from mosquito. And there's something that we can do in the community. So if people been, number one, being educated about what is dengue fever, being informed about how they can reduce, their containers or some sites that are breathing for the mosquito. So we can prevent that, like the photo being shown by my colleague. We can educate people to do something to reduce the breathing side of the mosquitoes. That would substantially reduce the risk of the Aedes, the mosquito that is spreading the disease. So that is something that can be done at a community level. And that would not require much budget. What is needed is just a team to inform. So number one question for you is that, do you have an outreach workers, community motivators, something like that in Hargeisa to do that? In many countries, there are outreach workers in the community. They can help the community to deal with some health issues. Not necessarily through providing medicine, but mainly through education and some efforts to change the behavior. That will substantially reduce the risk of dengue. Because dengue, the transmission is mainly through mosquito. If they bite, they got a virus, they will be able to transmit in their lifetime, the whole lifetimes. So the most important thing is not to have a high density of mosquito. So the question to you is that, do you think that would it be feasible to think about some education in the community to educate people what is dengue fever, to educate people how to reduce the chance of mosquito to multiply? Would it be possible to inform people how to reduce the the intensity of mosquito. So that's my question to you, in Hargeisa.
I think if someone else would like to answer that question would be good, as some of my colleagues are here. Dr. Abdillahi Abdi Ali. I think in the Ministry of Health of Somaliland, they do have what we call health centers. And the health centers are scattered throughout the cities and throughout the remote areas, including the remote areas. So they have what they call community mobilizers. I remember last time when we were dealing with the COVID outbreak, and also same as when we were dealing with the dengue fever outbreak, these people were mobilized and they were going to the houses near to the health centers and giving health education, how to prevent. And there was also a mass media campaign against, to inform people how is the best way to prevent dengue fever infection and what to do when, a patient or, someone from your family got a fever. So that information and that education has been started to, deliver to the community. But so far, we feel that still, because of the illiteracy, percentage in Somaliland, people who can read or can write, is very high. So in that manner, still we have difficulty of education our community and giving them a health education. But there's, generally in the worldwide, we all agree that prevention is better than cure, and that we have to do our best to, work on household levels, to raise awareness, and also to prevent breeding sites of mosquitoes. I remember in 2019, I've been working with an organization in Bruco. So they have started to, there was a fever of unknown origin, that outbreak of fever in Bruco. The cause was, later on we figured out the cause is chikungunya virus. Chikungunya virus. That time we haven't, found any patient with dengue fever. The possible differential diagnosis were included dengue fever. But when we have tested PCR, when we have done a PCR test, we found that most of the cases were because of chikungunya virus infection. So that's why we were saying, yes, it could be one of the reasons that the testing, capacity of Somaliland is not enough to, detect dengue fever or to detect any virus that comes into the country. But there are clinical symptoms, clinical, information that comes before we do a proper laboratory test. So that can inform us whenever we see a fever associated with like a rash, and also have some features of hemorrhagic, whatever we call them, hemorrhagic type fevers. We can know from there that there is a infection, an outbreak of these related viruses. So that's why we were saying the number was not, we haven't seen any previous outbreaks regarding the dengue fever. We were looking at the clinical findings and the information that we have been receiving from country, the country health posts. So we agree with that question that we need to strengthen and increase the capacity of health workers and also to educate our community. Thank you very much.
Thank you. I think that's crucial. So my further question to you is that from the emerging report in 2023 that I have seen about some event in Somaliland, that was in fact from the Ministry of Health and Development from Somaliland, perhaps through World Health Organization WHO office in Hargeisa to World Health Organization, saying that there was a report. There was an outbreak of dengue, but we don't know what is going on. So the report indicates that the WHO people, they sent a team to Hargeisa, to Somaliland, to do some testing. And the number of people being tested was more than 2,500. And more than 500 people test positive by the rapid diagnostic test. So it's more than 25% of people, they are test positive. So do you know what happened to those people and where do they go? I guess because this Hargeisa Group Hospital is the national hospital, so I guess that perhaps those people test positive. If they require healthcare services, they would come to Hargeisa Group. Was that the case or not?
We need to all, understand at first point that the data quality and the surveillance that we are doing in Somaliland is not completely, it's not complete and it's not strong enough to represent all, the numbers and also to represent the incidence of cases. There are only few data that is recorded to, and also reported to WHO, and also the testing, as far as I remember, where they were only testing people that have clinical symptoms of fever.
Sure.
So if you look at the time of outbreak, and you are only testing the people that have an outbreak, then the number of the incident rate is going to be high. So that's why the number you can see from 500 patients out of 2,500 or 2,600 that's why the number is so high. When it comes to what was the fate of that people, I really can't tell that because we don't follow up them properly. But most of the cases that came to Hargeisa Group Hospital, most of the severe cases were coming to Hargeisa Group Hospital. Dr. Ahmed was supposed to present it, and he will come later on. He will give us what was the number that we have received in Hargeisa Group Hospital, how many of them passed away, and how many of them recovered properly, how many of them had long-lasting complications. We have that information.
You have that information.
Yeah, so Dr. Ahmed, when he comes, he will share us or will give us a picture of what has happened at Hargeisa Group Hospital, because we have looked at the registers we have in our hospital. So that information I think is recorded and is available in Hargeisa Group Hospital. And Ahmed was looking how he will was looking at that information last week, and I hope that he has everything regarding the number of patients we have received and what was there, what they ended with. Thank you very much.
That would be fantastic. So would he be able to come today for presentation?
Yes.
Okay.
He will come later because
All right. So I guess it will be perhaps more informative after his presentations, so as to have a continued conversation.
Yes.
All right. Thank you.
Assalamu alaikum warahmatullahi wabarakatuh. Dhammaan waan salaamayaa kasoo qaybgalayaasha. Good morning for all the participants. Today I want to present a small highlight about the epidemiology of esophageal and breast cancer in Somaliland. Small statistics that we done in Hargeisa Group Hospital. So we will just first see an introduction and then how is the epidemiology of esophageal cancer and breast cancer in the world, and then Hargeisa Group Hospital statistics, and then small discussion, and finally the recommendations. So as we know, cancer is one of the highest burdens in the world now, and it occurs in 19 million yearly. And it causes the deaths of 10 million deaths each year. And cancer is causing the highest risk of mortality and morbidity in the world. And for Africa, it's affecting around 1 million. But the survival rate is low compared to the higher income countries when we compare it to Africa. So globally, the most common cancer that's diagnosed worldwide is breast cancer, and it surpassed the lung cancer, which used to be the #1 in the world. And around 1/3 of the cancers of the world is comprised of breast cancer, and lung cancer. So for male, as we already know, it is lung and prostate cancer, and for female, it's the breast and then colorectal. But still, lung cancer causes an increased it's the #1 cause of mortality in the world. So in Hargeisa group statistics, for the last year, 2023 and 24, we have diagnosed 562 patients who were included on the study. And out of these, 182 were diagnosed with cancer, and 53 were male, and 47 were male, and 53 were female. So these are the list of cancers that were diagnosed in Hargeisa Group Hospital, in numbers, in tabulation. So the most common cancer that were diagnosed is esophageal cancer, which accounts 27%. And the next one is breast cancer. The third one is prostate cancer, and then colorectal cancer. So when we see the cancer types, as I have said, it is the esophageal cancer, and then breast cancer, and then prostate. And we can see here that we have a low number of kidney and liver cancers in Somaliland, because getting the samples is very difficult. Because of the difficult of diagnostic modality, it's difficult to get a higher number of cases on kidney and liver biopsies. And for the female, the interesting thing is that esophageal cancer is as equal to that of the male. It's like, for example, the breast is 23.5, and then esophagus is 21.4. So it's as almost equal. So for the male, it's the esophagus, and then the prostate, and then the colorectal. So when you see the data from the WHO, which is associated in Somalia or Somaliland, they usually take the data from the nearby countries. It doesn't represent the local data. So in sex comparison, it's almost comparable, the esophagus in male and female. But on the other literature, esophageal cancer is more common on males worldwide. So the most common cancer that were diagnosed was esophageal cancer. 42 cases were esophageal cancer, and for breast was the commonest in female. And for esophageal cancer, it peaked around the age of 50 to 60 years. So this one is similar to other studies that were done in the nearby countries like Uganda, Tanzania. And as I have said, our study showed slightly equal male to female ratio. However, female predominance were reported in some of the countries like Sudan and Thailand. And the most common histological subtype of esophageal cancer that were diagnosed in Hargeisa Group Hospital was squamous cell carcinoma in 97% of the cases. Only that we had one case of adenocarcinoma, so that it may be related to the increased usage of over-the-counter medications like omeprazole. So another study done in Somalia, there is also an increased risk of esophageal cancer in female, as you can see it from here. It's almost equal. Males and females are almost equal. So esophageal cancer, it occurs around the esophageal cancer belt. It's more common in certain parts of the world, like in Asian countries. It's more common in Iran. It's more common in China and Russia. And for Africa, it's more common in Eastern Africa, Southern Africa, and it is less in Western Africa. There are less number of cases that were reported in Western Africa. And in some of the literatures, when I was reading, the highest esophageal cancer case in Africa occurs in Malawi. So when we see on the associated risk factors worldwide, the most commonly risk factors that are associated with esophageal cancer is tobacco smoking. Tobacco smoking is highly associated with the squamous cell carcinoma of the esophagus compared to the adenocarcinoma of the esophagus. And alcohol is also highly associated with esophageal cancer, especially the squamous cell carcinoma of the esophagus. And when we see on opium, opium is highly used in Iran. So the only study that was done in opium is Iran, and they have seen like 1.5-fold, 2-fold increase of esophageal cancer in the usage of opium. So there are also other risk factors like environmental factors, as they're saying, like indoor pollution. For example, we use highly charcoal for food cooking. So that may be associated with increased number of cancer cases in female, because it's really amazing to see a rural woman coming from the rural area that's having esophageal cancer. She doesn't use tobacco, she doesn't use alcohol. So what will be the associated risk factor? So maybe our usage of hot meals, the hot tea, hot rice, may be associated, and also indoor pollution of charcoal can be an associated risk factor in our setting. And for adenocarcinoma, it's mainly associated with GERD, gastroesophageal reflux disease, and obesity are the most commonly associated risk factors for adenocarcinoma of the esophagus. And for breast cancer, I think my other colleagues will talk about the management of esophageal cancer in Somaliland, and also breast cancer management in Somaliland. But as we can see, breast cancer is the second, or is the first common cause of cancer in female. And the commonest risk factors, we already know them. The common risk factors, the hormonal factors are the most important, increased estrogen. And I have a small video about breast cancer, which is saying more about breast cancer awareness. So we need mainly to teach our women the self-breast examination so that they can detect if there is a mass lesion early on. So this video is made in the USA, and it was translated. The actors are Somalis, and it has also a subtitle. So I think it will be helpful. And the language that they are talking is Somali. So we need to make more of such like these videos. Thank you very much.
iskuma xidhna baaritaanka guud iyo kan waa muhiim in la iska baaro kansarka naasaha waa muhiim in la iska baaro xaaji suumo ogi dumarku markay 40 iyo inka badan jiraan inay iska soo baaraan kansarka naasaha xaaji ballan iiga samee alayna hospital.
horta saa umaan ogeyn waan wacaa oo ballan baan kaaga samaynayaa alayna hospital.
With our setup. Yes.
Yes. Hi.
xaliima qolka dharbedelashada soo gal oo markaan waxaan kaa rabaa in aad jirkaaga inta sare dharka ka saartid oo aad cambuurkan gashataa adiga oo horay ka furaaya alaabtaadana armaajadan ku xiro anigana bannaanka ayaan kugu sugayaa oo marka aad dhammaysato ii soo bax
hadda maxaa lagu wadaa qolkii oo imtixaanka lagu qaadaya naasaha oo raajada lagaaga qaadayay gabadhaan heedar la sii soco marka. All right, come on with me.
saaga naaskaada inta u dhex
This will come down and it will compress your breast a little bit.
misaanka
Side.
laba sawiraan
We're going to do 2 pictures on each side.
laba sawiraan midkiiba ka qaadaynaa naasaha
This will come down and it will compress your breast a little bit.
misaanka kore hoos ugu soo degaya saanka kale ku cadaadinayaa markaas naaskaada inta u dhexaysa
Once we're ready to take the picture, I'll go back there and have you hold your breath and hold still.
markaan aan ku diyaariyo xaggaasaan tegayaa sawirka si aan u qaado waxaana ku dhihi doonaa neefta isku celi su-aal maa leedahay saa soco
Good. Okay, this is going to come down.
xoogaa yaray soo deganaysaa
Okay, hold still.
ha dhaqaaqin
Hold your breath.
ha neefta isku qabo
Good. You can breathe.
waa neefsan kartaa marka
Okay, good.
waa ku dhamaata marka hadda sidaa ujeediin waa qolkii raajada markii laga soo qaaday ama imtixaanka naasaha laga soo qaaday gabadhii halkaanay usoo gudbaysaa dhakhtarkiyaa fiirinaayo ama aqrinaayo hadda sawiradii lasoo qaaday markaas maxay natiijada ka timid ayuu soo sheegi doonaa iyadoo faahfaahsan oo kusoo diri doono warqad qoraal ah ama maxay ahayd inaad systemka online haddaad leedahayna aad ka geli kartid ama warqadda ay boostada kugu imaan doonto insha allah intaasay maxay ahayd
السلام عليكم. وعليكم السلام. ما لك في عين أبلغه. حالة كورن. فرنتي ما يدسوا قاعد. الوقت هنا هبو دمر أفرتن إنك بدن هدي جيران إني مهم تهي الله إسكبارو كانسر كناسها قلا.
وحقالة إسكباريا.
علينا هسبتال يلا إسكباريا. بلنتين وا علينا هسبتال.
والآلين إن شاء الله.
Oh God, tiny they are.
Every single day I look at them and I'm like, you may not be.
Text, please go back.
Previous one.
maanta waxaan rabnaa in aan
The slide.
Slide, yes.
So these are the challenges that we face are for late diagnosis. Our people will come. Our people always comes when they are symptomatic. For example, esophageal cancer, if it becomes symptomatic, it's most probably or higher probably in higher stage when the patient presents with difficulty of swallowing. So late diagnosis is one, and advanced stage, our people, they usually come late, so they come with metastatic disease. And the higher cost of investigation, for example, in someone to do an endoscopy, he needs to have $200 at pocket. So this is also one of the challenges, higher cost of investigation and lack of service in many areas. And the recommendations that we are, that I'm suggesting is to have a multidisciplinary team and the standardization of cancer care in the country, and to have a local guideline for the treatment of different types of cancers, and to increase the cancer awareness. Since diagnosing and treating cancer is very difficult, it's better to raise and increase the awareness for the general population. And for these studies, since it's a preliminary studies, we need to have a further studies which are mainly focused on what are the risk factors associated with esophageal cancer, what are the causes. So further and deepening research is also necessary, and to design mechanisms for early detection. And our country has no tumor cancer registry. So always they say like data is the oil, it's like an oil. It has a much value. So we need to have tumor cancer registry in the country. Currently there is no, so we are sending a message to the Ministry of Health in here to have a cancer registry in the country. And thank you very much.
Thank you, Doctor. And nice presentation. Yes.
Hi, thank you for your presentations. Well, number one, I understand that the data because it represents only data from one hospital. It's Hargeisa Group Hospital, but Hargeisa Group Hospital is a big hospital. But the number of patients with esophageal cancer was so high, the proportion is high. But because I know that in Somaliland, people don't drink alcohol, right? So alcohol, perhaps small, tiny fractions they drink at home, but I guess the majority they don't drink. So alcohol consumption likely not a risk factor of esophageal cancer in Somaliland. Tobacco looks like a potential one. So my question is, how many people smoke? The proportion of smokers in Somaliland, among male, among female, do you have any data? Is that a common behavior, practice, smoking, or is not so common in Somaliland? That's my first question.
Thank you very much for the question. As you have said, esophageal cancer is the most common cancer, but alcohol consumption is low in the country, very, very low. But smoking can be related to. For example, there is a higher proportion of smoking in males compared to females. But in our data, they are very close. Male and female ratio of the esophageal cancer is very close. So mainly the old persons, they use chewing tobacco rather than the smoking. They use something called buri. So they put it on the buccal mucosa. So maybe that one is related to esophageal as a risk factor for esophageal cancer, but not for women, because in women they don't use much. But the other things that are most commonly used in the country is the hot drinks, the hot tea, the hot rice, and the tea added with ginger. So there is a common culture of drinking hot tea on the spot. So maybe that's related. Also chewing chat. There are some of the studies which were done in Kenya concerning on the Mira cat. So that one is also associated with esophageal cancer.
Yeah, I understand that drinking hot tea perhaps is quite common here. But it's also in my society, we also drink hot tea and hot soup. We drink every day, yeah? Hot coffee, hot tea, hot soup. It's our common daily practice in Taiwan. I don't remember that we have so many esophageal cancer.
Maybe you had dessert after that.
Huh?
Maybe you have dessert after that.
I don't know. But we don't chew the cud. Some people chew, we call it bitter nut, but not the cud. We don't have that. Indoor air pollution is quite common in all the resource-limited settings. I mean, the whole Africa, more than 70%, 80% of households, they're using solid fuel for cooking and heating. That's common practice. So my question, in fact, is about female. It's quite difficult for me to understand. But the data that you show is proportion. But still, it's strikingly high. And the data that you have shown seems to indicate that cervical cancer is not an issue. But I'm not sure that's correct. Because the data that I have from WHO is about Somalia, not Somaliland, because there's no data about Somaliland. But because cervical cancer is highly, it's quite aggressive. But esophageal cancer also causes a lot of mortality. So I have difficulty to understand, from the data from WHO, breast cancer is the leading cause of mortality, cancer mortality. Cervical cancer is number 2. Esophageal cancer is number 7. They are 6.2%. No, it's 6.2. I don't know what would be the denominator. Maybe it's a population level, because it's mortality rate. So it's population base. So it looks like, and lung cancer usually is not a big issue, not yet. It's coming, but not yet a big issue in resource-limited setting, because it's mainly in the past, the behavior of the North America and the European. The female, they smoke a lot. So they have very high lung cancer. The data that you show high lung cancer is mainly among high-income countries, not low-income countries. But cervical cancer, there is a global strategy for cervical cancer elimination, because it's doable, it's preventable. So I'm wondering about your perspective about esophageal cancer, about cervical cancer in female.
One thing, before Omar goes to, as I told you earlier, there's a issue about the quality of the data we have in Somalia and Somaliland together. So even this data you have here and this incident rates you have here cannot represent exactly what's going on in Somaliland. As we need to have a countrywide registry to register and see exactly the number of cancer cases identified and diagnosed, and also compared to that population denominator is what is required. So at this level now is early beginning, which we are now trying to register the number of cancer cases coming to Hargeisa Group Hospital, and also include those come for Hargeisa Group Hospital for just only diagnosis. Then that is exactly, if you look at our pathology center, which has been working for the last 3 years now, 2 years actually, has only recorded those cancers that we have presented here. But we have also opened now recently a pap smear, a cervical cancer screening unit within the obstetric and gynecology department at Hargeisa Group Hospital. And this also will give us later on, the incidence, the number of patients coming for, coming with cervical cancer. But generally, our people, and most of the cases, they will come at a terminal stage. When they come, they will come to the referral hospital, and that time they don't represent exactly the percentage and how many they are from out of the country population. I think Omar will also add some, information to that, but this data is not enough to tell us the exact number of incidents of cancer in Somaliland.
But you see that, I guess it would be too late to wait until you have perfect data. Yes. Perhaps it's essential to take action even before you have perfect data. So if something that is doable, that perhaps we should try from the outset. if something is preventable, perhaps you should try.
Yeah, in a minute or in the next session, Dr. Fadumo is going also to talk about the breast cancer screening.
Breast cancer.
Yeah, so this is also another activity that has just
that's
started.
good. Yeah.
So yes, as you said, we have to take an action immediately.
Yeah.
I only just want to add one point. As you have said, one of the limitations of this study is that it cannot represent the whole country. And the other problem is that since most of the patients, they come late, there are a lot of outside referrals. So most of the cancer patients, they go to abroad. And as you said, the cervical cancer data in Somalia, I have already mentioned that it cannot represent the local context because it usually they usually take it from the nearby countries. This data is the same as the one of the nearby countries in which WHO has figures. Since we don't have any data in here, it cannot represent. But what I am telling you for sure is cervical cancer is one of the least cancers in the country. The least, yes, one of the least cancers, very low. As far as I have seen in cervical cancer cases, I think I have seen 3 advanced cervical cancer cases in my stay in here for 2 years. So cervical cancer is very low. But you have also asked me about lung cancer. In lung cancer, as I have already mentioned, there is a diagnostic difficulty of taking core biopsy from the lungs. So since there is a diagnostic difficulty, we don't see any case from the lung. But you can see some of the referrals going to abroad being diagnosed as lung cancer. I think lung cancer is more than cervical cancer in the country.
Yes, I think it's very difficult to make policy based on data of Hargeisa group because of the uncertainty of the data. It's very difficult to know. So I think it's very important for Somaliland to come up with a national strategy. So now question for you is that do you have a national cancer prevention or strategy, something like that? National plan against cancer in Somaliland? Do you have that?
I think it's been only last year when we have started, publicly announcing that there is a high rate of cancer in Somaliland. So this awareness has just recently come to the public issue, and it has become a public health issue. So I'm not quite sure what is the Minister of Health of Somaliland is going to do about this. But as Hargeisa Group Hospital, we have just started in collaboration with Taiwan ICDF to create a health system registration, a health information system in Hargeisa Group Hospital, and that will help a lot in data collection and later on data analysis. But so far, we see this as an issue, and this is something that we need to take an action on it. And hopefully, maybe Minister of Health of Somaliland will also take a similar action in terms of data collection, diagnostic tools, and also management of cancer patients. So something for Somaliland people to work on.
Sure. Can I ask you one question? In Hargeisa, how many hospital has pathologist has the capacity to make a diagnosis of cancer? Hargeisa group is one. How many others in Hargeisa? How many?
I think 2 others.
2. So the total is 3. 3 sites, 3 hospitals. How many pathologists each? So how many pathologists at Hargeisa group? And how many pathologists here?
We only have 1 local pathologist, and that's Dr. Omar.
You are the only local one?
Yes.
And who are the other 2? They come from outside?
Yes.
Huh?
Yes, they are from outside.
Nido Hospital? And then the other one, which one? Okay. So my question is that looks like if you speak to each other, 3 of you sit down put your data together, you have more representative data about Hargeisa, I guess. But then, of course, we don't know who would come to you. Perhaps those living in Hargeisa will come to you, the 3 hospitals. Perhaps some outside Hargeisa will also come to you. But at least, if you put the 3 people together, have a cup of tea, talk to each other, put your data together, would it be possible to have at least a better data about what is going on? Can you do that? Yes. Is it feasible?
Yes.
I would suggest that you try to do that. So now,
I think there's already a collaboration between the Hargeisa Group Hospital and Needle Hospital, and they have already produced some sort of report about the incidence of cancer and different categories of cancer they have seen so far. So I think there is a communication, but we can make it more, formal, and sit with them and look how we can cooperate. And that's a good suggestion. I think we will work on that.
And then follow up after that question is that how many pathologists you have outside Hargeisa? Zero. So meaning that in Somaliland, you have only 3 hospitals able to do this kind of work, right? So I guess patients with cancer in Somaliland, they will only come to 3 of you. They may go outside, go abroad, but that is, I guess, is just a small, tiny fraction. I guess the majority of people will not be able to go outside because it's expensive, isn't it? They may be under detection because people cannot come forward. So they will die at home without diagnosis. But those who manage to come would have diagnosis at the 3 sites. Those who make a diagnosis outside is not going to have a big impact on the data that you have. So I would guess if 3 of you put your data together, that will be likely sufficient for action, isn't it? Because if you have an annual number, then it's a diagnosis. There will be always delayed diagnosis, that's for sure. But based on those informations, you'll be able to know on an annual basis how many lung cancer being diagnosed, how many breast cancer will be diagnosed, how many esophageal cancer, how many cervical cancer being diagnosed, right? Then they will take the population into account. More or less, you have a detection rate, not instance. It's a detection rate at population level. The detection rates and the instance, there's always a gap because detection cannot be 100%, given the access to care may be limited. But I guess you will be in a better position to know what is going on in your country. And you'll be able to perhaps show more convincing data as compared with the data from WHO. Because from your statement, it sounds to me you do not trust the data. You are suspicious. You may not believe the data presented by WHO. So why not put together the 3 of you, show your data, and publish? Why not do that?
Thank you for these important suggestions. And as we already said, this is just the beginning of what we are, trying to achieve in the coming years. As you see now, we only have 1 local pathologist. We are now expecting other pathologists to come to Somaliland, and we only have the cancer histopathology unit in Hargeisa Group Hospital for only the last 2 years. So there is a potential of these new specialists and also this new health cancer center.
National Agency for Research on Cancer estimated that there were 2.26 million cases of breast cancer. And of these, 685,000 were a result of breast cancer deaths. So this was 2020. If you can see for the incidence in the brown color, we have the breast cancer leading the incidence, and in mortality in the purple color, lung cancer is always the highest in mortality, but breast cancer was the second close. For 2022, the statistics that we have, if you see the incidence report in blue, what we have is for the male in incidence is the lung cancer. In the green area, we have prostate, and in the pink, which you can see that's affecting all the continents in Northern and Southern America, Europe, as well as Africa, is the pink is in breast cancer. So an important thing to realize here with the mortality is, if you go back to this picture, when it's the incidence in North America and South America, as well as Asia and Africa, everything is labeled in pink. But when it comes to mortality in females, breast cancer being the leading cause, the North America and a lot of the European countries, they have a reduced mortality of the breast cancer, even though they have a higher incidence. So the point of me raising the global statistics of where breast cancer stands now, according to Dr. Isabella, who's the deputy head of surveillance at the branch of the International Agency for Research on Cancer, if we see in the blue, which is the incidence, in the European countries and a lot of the Western countries in America, there's a very high incidence, which is in the blue color. So the mortality is in the red. If you notice, they have a higher incidence than us, but when it comes to mortality, they have a lower mortality than us. This is us in East Africa. We have a 17.6 mortality for breast cancer, while in Australia or North America, you can see the mortality rate is 13. And this is because countries with high development health index, they have a higher incidence, but they detect the disease early and they can treat it early, so the mortality is lower for those countries. So a brief summary of what breast cancer is. We know these are tumor cells or malignant cells that are arising in the ducts or the breast tissue or the lobules producing the milk and draining it to those ducts. And it spreads to further distances in the body because it travels through the lymphatics or the blood. It reaches the brain, the bones, and the lungs and the liver. Some of the risk factors we can look at, so automatically being a female gender puts you at 100 times more likely to develop the disease. It does not mean it does not happen in men. Male have a 1% of contracting the disease, and sometimes even more aggressive in male than it is in females. When it comes to age, it is usually seen in the 5th decade. Family history is a strong risk factor, especially if you have a first-degree relative, and even more so if the relative is diagnosed before the age of 50. The menstrual cycle plays an important role in the development of breast cancer, or puts you at a higher risk if the menarche starts below the age of 12, or if you get menopause later than the age of 55. The bearing of children also plays a role. So nulliparity, or women who have no children, women having children at an older age, they have an increased risk of developing breast cancer. Breastfeeding has been, in many articles, seen to give a protective layer to women. So but that only includes when you breastfeed for 1.5 to 2 years at the minimum. Some lifestyle risks are if you have taken contraceptive pills, which are estrogen-based for a long duration, and patients who have received hormone therapy during their childhood, and carriers of BRCA1 and BRCA2 genes. So this is a small brief introduction on the types. There are many types of breast cancer, but ideally the ones, ductal carcinoma in situ means it's within the duct and has not infiltrated into the surrounding tissue. Invasive ductal carcinoma accounts for 75 to 80% of breast cancers, and lobular cancer is the second most common, which accounts for 10 to 15%. Inflammatory breast cancer is in a category of its own, and then there's metastatic cancer. So these are briefly the stages. 0 meaning the tumor cannot be detected, it's not present. Early stage is it's confined within a small area. Localized means it's within 2 to 5 centimeter in its greatest dimension. And regional spread to the axillary lymph nodes, to the tissue of the breast itself, and the tumor size increases to more than 5. And then in stage 4, we have distant metastasis involving other organs. So in the AGCC cancer staging 8th manual, what's important is, and this is clinically used both by the pathologist and the radiologist, the oncologist, and the surgeon, is that they've added a prognostic factor. So we know T means the tumor size, and N means the number of lymph nodes that are involved. And this is the clinical lymph node, means first, if you have an N1, you have lymph nodes that are ipsilateral or on the same side of the tumor, but is mobile. And then N2, it's again within level 1 or level 2, but it's fixed. And N3 means it's involving the inframammillary, infraclavicular, or the third zone of lymph nodes. So the prognostic one now, the pathological and prognostic in AJCC staging, is important in deciding the stage of the patient, the prognosis, and the treatment that they will receive. Another important factor of when we're investigating a patient with breast cancer is to not only look at the histopathology of the tumor, which tells us the grade or the stage of the disease, but to also do receptor analysis. This is important because it takes an important role in which management we're giving to the patient. And these receptor positivity tumors have a more tendency to have a reduced recurrence and also benefit from hormonal therapy and chemotherapy better than those who are hormone receptor negative. So we have estrogen and progesterone that the breast uses for its growth. The tumor cells that are positive for ER will be called estrogen receptor positive tumors. Those that have PR positive will be called PR positive tumors. And then there's the HER2, which is a protein that it is used very much by the breast tumor cells to grow. So these three things, if a patient has a triple negative breast cancer, which means ER is negative, PR is negative, and the HER2 is negative, they're more likely to have a BRCA mutation, whether it's BRCA1 or BRCA2. And these kind of patients with a triple negative disease, they tend to have an aggressive tumor, which is much more difficult to treat. What are the signs and symptoms that the patient will present with to the hospital? So a patient might come with a lump, some thickening, if not necessarily always in the breast, but sometimes also in the axilla. Some patients come with nipple discharge that may be abnormal, and a change in color in the texture or the skin, or the scaliness or dimpling of the skin, which we call peau d'orange. And sometimes they might not even detect a lump in the breast, and instead they might see a change in the position of the nipple, but it's the mass or the tumor that's pushing the nipple into an opposite direction. Now, when it comes to pain and tenderness, it's more familiar to have pain or a patient coming to the hospital with benign disease if they're complaining of breast pain. With malignancy, it's usually a pricking sensation, a burning sensation. It's not the same as fibrocystic breast disease or mastalgia. When it comes to investigating, again, breast cancer has to always go through a multidisciplinary approach. It's not something only the surgeons will handle. There is a number of faculties that come together to improve that patient's outcome. So when a patient first presents to the clinic, they need a clinical breast exam. So as Omar mentioned, self-breast examination is something that we need to incorporate into the breast cancer awareness so that people can detect the lump and present to the hospital earlier, where they get the clinical breast exam, and then you can decide whether it's a malignant lump, depending on the irregularity of the margins, the hardness, and so on, followed by radiological exam. So triple assessment means clinical breast exam, the radiological exam, depending on the age that the patient presents to us. If they're younger of age, they have a denser breast tissue, so we send them to get an ultrasound to confirm the size, the site, the location, and the character of the lump. And if they are older age or above 35, we suggest a mammogram. And then finally, tissue diagnosis. Tissue diagnosis, sometimes we use FNSC, which is a non-invasive percutaneous procedure, but it's far more accurate to use core biopsy, which I believe we have the TrueCut needles available in the hospital and the histopathologist available, so we can take advantage of getting more accurate results. And for patients who do not have a palpable tumor and is detected only on mammogram, what we use is a stereotactic biopsy. Some of the other investigations we need to send besides only focusing on the breast, since we know that breast cancer has a tendency to metastasize, what we need to do in our low resource setting is, if it's a stage 2 or above patient, you start with the basic necessities that we have, the modalities that we have in the hospital. So for patients with T1 or T2 staging, if a patient has increased alkaline phosphate or they have tenderness over the bone when you're doing an examination, you can get a CT scan done, otherwise not. If you have abdominal symptoms or tenderness, or you have abnormal liver function tests, then you can go ahead and get an abdominal CT scan. If the patient has symptoms in the pulmonary or there's signs of effusion in the chest X-ray, then we go for the CT. But otherwise, just an ultrasound abdomen, the basic liver function profile, and chest X-ray is sufficient to get the first reading on the patient. And for patients with stage 3 or above, it's important to do the bone scan, the CT scan, abdominal pelvic, as well as the chest, because even in the absence of symptoms, you have to rule out metastasis. The treatment modalities will be broken down into where the location and the extent of the tumor. So local regional means we do surgery followed by radiotherapy, and then the systemic treatment is chemotherapy, hormonal therapy, and immunotherapy. For the surgical local regional treatment, the trend now is moving towards conservative breast conservation treatment. And for breast conservative treatment, it's a bit challenging to offer that modality in our setup. Limitations being the patients are usually coming at a later stage, so the tumor size is quite large, but also the lack of availability of radiotherapy, which is an important component of BCT. And these are some of the contraindications for why we cannot do breast conservative surgery. A patient who's pregnant, the lack of availability of the radiotherapy itself. Some relative contraindications are those who test positive for the BRCA genetics, as well as they have received previous radiation to the chest wall. So these are the components of breast conservative surgery, where you do a wide local excision or remove a segment or do a lumpectomy, quadrantectomy, followed by sentinel lymph node biopsy. And then if you detect a lymph node, you go for axillary clearance, and then radiotherapy. The radiotherapy is usually a component of breast cancer because to minimize the recurrence at the margins. And then oncoplasty, which can either be immediate or delayed. This is for the breast diseases that are usually in the later stages. Axillary lymph node is supposed to have a dissection. This is part of the NCCN guidelines. And the outcome, it depends on the compliance of the patients. When you remove a breast in its entirety, you have to be able to offer that patient oncoplastic recovery and reconstruction, because it helps people in trusting you to come to the hospital and get the procedure. Living with a defect, that too for a female, is a stigma, and it pushes that patient down another line of depression and self-isolation. When it comes to axillary clearance, it's important that when we do the dissection, even if we do it up to level 3, that the minimum of 10 lymph nodes should be extracted. Radiotherapy is just a few points here. We do not have access to this here, but these patients benefit from radiotherapy if there's a high risk of local regional recurrence, if there's positive margins, if the tissue, underlying tissue or adjacent skin is involved, and it's highly beneficial to give a complete treatment to the patient. In systemic treatment, the last one being neoadjuvant, adjuvant, or chemotherapy, we have the combinations available in private hospitals, but they're still available in the country. And it's important that we'll come to the rationale, to the issue at the end when it comes to the gaps we need to fix in the healthcare system. But the neoadjuvant therapy that a patient is getting to reduce the size of the tumor, to make it more operable, to downstage the tumor if you were considering breast conservative surgery. And this allows you time for planning the patient's surgery, where the plastic surgeons, the surgeons, and the radio-oncologists are discussing a panel discussion on each patient. So the candidates for neoadjuvant therapy, like we said, if it's a large or bulky tumor, if there's matted lymph nodes, if the tumor size is T4, these patients benefit from neoadjuvant chemotherapy, and this helps in the surgery that they're getting. For hormonal therapy, the reason we were doing receptor positivity or negativity in the breast cancer is because these patients can benefit, if they are HER2 positive, they can benefit from receiving medication, which even if it gets into palliative care, it helps in the palliative metastatic disease, but also it's used as a prevention in patients with high risk, and it gives a higher prognosis and reduces the recurrence in patients with ER/PR positive. For oncoplastic surgery, what happens is when we do a modified radical mastectomy, what you need to do is to reconstruct for the patient something similar to the anatomy that they lost. And in order to do that, timing of the reconstruction can either be early or, and we do not have all of the components like sentinel lymph node biopsy or the frozen section or the radiotherapy. But what we are able to offer, which now is the standard, is modified radical mastectomy followed by the axillary lymph node dissection. And after we offer these patients the modified radical mastectomy, the implants, whether it's for the plastic surgery, we do not have it, but general surgeons do a rotation in plastic surgery, and we can do the reconstruction. These are just some of the types of the reconstruction that's used. The deep is usually muscles, abdominal fat that's coming from the abdomen, and it doesn't include any muscle. Tram flap is when we use the tissue and the muscle from the belly area, and this has a restriction that the patient, when it comes to lifting, because of the location where we took the flap from. Latissimus dorsi is another common reconstruction option for patients. The gluteal flap, which we don't take muscles, it's just tissue from the gluteal area, and a procedure that's called tug, which we use the fat and the thigh to fill up the space. So when it comes to breast cancer, we do know that it's present in the country. We do know that we have limited resources. With these limited resources, what are some of the issues that we're facing? So number one, there's a lack of awareness in the community. So as we all know, there's World Diabetes Day, there's World Tuberculosis Day, but October, the entire month of October, is World Breast Cancer. So we need to take advantage as a community, as the healthcare providers, as the Ministry of Health, to incorporate an awareness campaign that we hold every October to reach out to schools that are predominantly female, communicate with them the habit of doing self-breast examination so they can detect a lump and then come to the hospital early. And in order to do that, now I think Dr. Adnan will give us a few points on that. We are starting breast screening services. It's important for the patients in the community. If we're telling them breast cancer is treatable, come to the hospital, it's not a guaranteed death. In order to ensure that, gain that trust in the community, we have to have breast cancer screening services in the hospital, which might not take a lot of resources. We already have the histopathology, the FNSC, and the ultrasound available in the hospital, except for the mammogram. And the patient compliance to complete the treatment is quite low. That could be due to a number of reasons. People are not aware that the surgery is available in the country. So a lot of the people, when they're even diagnosed in the private hospitals, they will prefer to go outside. So we need to release this into the community that it's a surgery which just one of our colleagues is here has done last month, a modified radical mastectomy, and the people need to know that it can be offered in Hargeisa Group Hospital. So some of the limitations are within the healthcare system. When it comes to the frozen section, these kind of breast conservative surgery we cannot do because it's not a service we have. The sentinel lymph node biopsy, which is an important marker now according to NCCN guidelines, that instead of going for a full axillary clearance, you should be guided by the sentinel lymph node biopsy. And radiotherapy, which takes an important role in reducing the recurrence of a tumor, as well as chemotherapy and mammogram. Again, the financial burden, because chemotherapy or breast or any cancer for that matter, treatment is quite expensive. And then we need to create sort of a memorandum of understanding between what the group hospital is offering and what the private hospitals are offering. So when we have that kind of connection between the group hospital and Needle or any other hospital which is privately offering these chemotherapy drugs we do not have in the hospital, it reduces the delay in the patient's treatment. So as soon as the patient gets a modified radical mastectomy, the people in Needle should immediately follow up with the chemotherapy instead of having a delay or a gap between the treatment. So what are some of the things we can do? Holding annual breast cancer screening campaigns and visiting the schools where there are predominantly female students in the universities, holding surveys to see who is aware of breast cancer as a disease, what idea the community has about breast cancer itself. And this helps connecting the people from home where they're just hiding the disease, one, because they're afraid as a community, and in our tradition and the religion, they're hesitant to come to a hospital and show a male doctor a breast issue. So once the people are aware that there are female doctors available and there are male doctors available and the services of breast screening has been started in the hospital, they will come out of the home instead of staying home and continuing to progress the disease in different stages. Another important factor that we've mentioned also before is having a cancer registry, because we cannot keep relying on the WHO or estimates of what the neighboring countries are having. We need to know our own numbers so that we know what we can do and how we can improve it. And having a breast cancer screening, which is now set up to be started in group hospital, since they have done the pap smear and follow up with also the breast screening, is once we've established it in the main tertiary care of the capital city, to employ the training staff into different hospitals in all of the government setups, as well as the peripheral hospitals, because the disease is all about early detection. So when someone in the periphery detects a tumor, they can immediately refer the patient to the tertiary center. Creating screening guidelines and training the staff, strengthening our healthcare facilities, whatever is missing, like the mammogram and so on, and then building a strong inter-hospital referral system to prevent the delays between patient treatment. So I'll give you a brief summary of the kind of patients we get. Already Dr. has mentioned that usually what we're getting are very late stage tumors when it comes to breast. They're far and few. There's not a lot of people reaching the main tertiary care hospital. The reason being whether it's a cultural stigma, whether they don't know that it can be treated in the country, or whether they themselves are unaware. So by the time the patients reach our hospital, it's usually stage 2 and above. It's very rare we even see stage 2. It's fungating, it's ulcerated, it's metastasized, they've come with a complication of the pulmonary and the bone mets. So some of the patients might be diagnosed within group hospital, others are being diagnosed outside in the private hospitals. But once they get the diagnosis, where we can tackle the issue of starting the treatment early, as well as making the connection between, we have one setup of the treatment here in the private setups that's offering the chemotherapy, and we have one setup in the main tertiary care hospital. Building that connection between the two prevents delays, which is exactly what's happening a lot of the time. So part of why the people are reaching the hospital at a late stage is the hesitancy that we mentioned to come as a female to a hospital and present with a breast issue, present it to a doctor. And secondly, it's an expensive treatment. So the fact that it's expensive alone is not playing a role. They do not know that the treatment is able to be offered in the country. So it takes them a while to gather passports and visas and collect the funds to go abroad. And in that much time, the disease is progressing. So stage 3 and stage 4 patients that we are seeing are getting palliative care. They're admitted in the hospital for palliative management. Those that we have received within stage 3 or stage 2, late stage 2, we were able to provide them modified radical mastectomy. Just that last month, one of our colleagues has done it, and the patient went home and was referred to continue the oncology therapy. Again, we have a long way to go when it comes to reconstruction and everything, and then coming to a point where we have radiotherapy available, we have frozen section available, we have sentinel lymph node biopsy available that we can offer patients, because telling a patient we're going to remove the whole breast versus telling them we're going to remove a conservative part is a huge deal in gaining the trust of that patient. So I think all in all, the breast screening is where it starts, and it's important to continue it, to make it consistent, and to come up with our own data and involve the community as well.
Thank you. I'm sorry that we are late because we have another meeting while you're presenting. But I'm Dr. Jiang from Taiwan, from Taipei Wanfang Hospital. I think the subject that you present are very important and crucial. The data that we have may not be accurate, but indicating that breast cancer is the most common type of cancer among female in Somalia. Well, we don't have data of Somaliland alone, but I guess that also remains the same. The breast cancer is the most common type of cancer among female here in Somaliland. My question to you is that what do you think about cervical cancer? Because in many countries in other countries that we have seen that cervical cancer is also the top leading cancer in other parts of in Africa. For example, in Eswatini that we just visit, the cervical cancer was quite common. And so there has been a global strategy for elimination of cervical cancer. But then from earlier presentations from the Hargeisa Group Hospital, cervical cancer the number was so small. So now I got confused. So I'm not sure what is going on. Either cervical cancer is not an issue here in Somaliland, or it has been a neglected disease due to perhaps some cultural issue or behavior issue or healthcare issues or So what's your observation? What do you think about the cervical cancer in your country? Thank you.
Thank you. That's a very important question. Once again, I think the options that you gave was whether it's the fact that we're not aware that the disease is present and the fact that it's being neglected. It's not possible with the global numbers of cervical cancer that we have very low levels. What we're seeing is just recently, meaning within the last 2 years or year or so, is when we've started paying attention to screening these patients for cervical cancer. So like I said, he mentioned the gynecology department has started pap smear and staining. So the data is just going to start from now onwards. The fact that the figures are low does not indicate that it doesn't occur in the country. It's because we do not have evidence of it. So just the same way that under the same umbrella, hopefully, we're starting they've started the cervical cancer screening and the pap smear. We progress it to breast cancer screening, and then we release this out to the community. You increase this awareness and you tell people to come to the hospital at this certain ages for the certain screenings, whether it's breast or cervical. And once this is collected with the histopathology, with the gynecologists that are available at the hospital, we will start to understand the actual numbers. And then it will only increase from there on, because one lady will come and find out a disease, and then she'll get a treatment early, and then she'll go back into the community and tell the neighbors and the friends and the relatives by word of mouth. So it's important that we can't really say, oh, Somaliland is safe from cervical cancer. It's just the lack of the numbers, the lack of the people being aware that they need to get this screening done. So it has to be a campaign released by the Ministry of Health in association with the group hospital, and make it a common thing, and then extend it also to the peripherals also.
So then I have another question is that from previous presentations, he showed that the number of female got esophageal cancer was so high compared with cervical cancer. So because the resources are limited, so now I'm got confused again. Would it be more productive to focus on esophageal cancer compared with cervical cancer? Or because it's so low, cervical cancer is so low, and esophageal cancer is so high. So what's your take on this message? Was because esophageal cancer easier to diagnose? Was it because esophageal cancer causes a lot of symptoms, so patient cannot tolerate it, will come forward? Exactly. And the cervical cancer, perhaps people would neglect, or perhaps because of the cultural issues, they would reluctant to come forward. I'm not sure which way should we go. So because we from the Taiwan medical mission here has a small number of budget and also very limited budget, limited human resource. So what would be your advice? Should we spend our budget and human resource on esophageal cancer among female, or should we prioritize that for cervical cancer detection and management? What would be your advice? Thank you.
Thank you. I think in one aspect, sort of having two things running parallel. We mentioned esophageal cancer being higher in numbers. The histopathologist, the figures that they've stated earlier, is a person who's having difficulty to swallow will not stay at home. Whether it's female or male, they're going to come running to the hospital. Oh, I cannot eat, now I cannot drink. The person is immediately, even if they're presenting late, they will come to the hospital at some point. With cases like with cervical cancer, again, whether it's the cultural inhibition, whether it's the female stigma attached to, perennial diseases, we see it also in things more benign, like hemorrhoids. They will come at a later stage simply because of the location of that pathology. Patients are not confident or comfortable to come to the hospital for these diseases. So if we put the focus on, again, I'll hand the mic over to the deputy, he might be more direct in understanding where. But once we release the campaign, a campaign is just social media outlets and releasing into the news and the national television, which everybody is watching these days, that we've started screening the cervical cancer. We're doing breast screening in the group hospital. We will see more patients coming out of their home. When you tell them that the services are available, you'll be checked by female doctors, they will feel more comfortable to come out of the house. And we will get a more accurate number for the cervical cancer. So when it comes to the campaign of breast cancer awareness or cervical cancer awareness, is not going to demand that much of a budget, because our focus would be just to create the awareness first, to bring the people out of their homes. So the histopathology is already there in the hospital, the ultrasound is already there, the mammogram is something that's in the development. So once we have the services available, we can then decide for esophageal cancer the kind of treatment modalities they need and what kind of budget it would need for supporting that disease and the treatment of it.
So from what you're saying is that, because my understanding is that in Hargeisa there are only 3 pathologists. Before your presentation, our conversation was that perhaps to put the data from the 3 pathologists, we might be able to get a big picture of what is going on in Somalia. But from what you are saying, perhaps that would not be really informative. It could also be misleading, because what you just described is that a patient with difficulty in swallowing, they will come forward. But if they got some trouble for their genital organ or something like that, they will not come forward. So meaning that if we put 3 pathology together, even we see a high number of esophageal cancer, it may not be really reflecting what is going on in the country. Indicating that perhaps we still need to think about whether cervical cancer, work on cervical cancer, but doing some, as you had just described, the pap smear, and then get more information before making the final decision about cervical cancer prevention and management. Because there has been a global strategy for elimination of cervical cancer. So I don't know whether you have that kind of strategy or not in Somaliland? Do you?
It's not implemented.
Not yet.
Yeah, it's not implemented.
Okay, so.
Thank you all. Thank you, Fadumo, for this great presentation. I would just like to highlight once again that the issue of cancer was not on the table of policymakers and it was not a public health issue before. The reason, just to clarify, is that because we were dealing on more, like infectious type of disease. Somaliland were like, as other sub-Saharan countries were having burden on outbreaks of diarrhea, pneumonia, and under 5 killing diseases, mortality rate was very high. So the focus was to treat and to manage and to prevent that, mortality to occur to under 5 children, and also to prevent preventable diseases. But now, as you can see, as we are progressing, as we are making development regarding management and prevention and doing mass campaign vaccination against the infectious diseases, now this issue has come to the table of the ministers and even it to the referral hospitals like Hargeisa Group Hospital. So this whole issue is something new to Hargeisa Group Hospital, and we are trying our best to collect the possible available data in Hargeisa Group Hospital and also to collaborate with other local hospitals to get the information and also to utilize that information to direct our management and also our intervention to this burden. So I think maybe next year when we come together, we may have more solid information, we may have more accurate and reliable data when we add all these information that we are receiving from different hospitals, from different health centers. So I think at the moment, what we all agreed is we need to do something about this issue. So we have now started the pap smear screening. We have started breast screening at Hargeisa Group Hospital. Already the histopathology is working well, and we are doing the biopsy, cord biopsy, fine needle aspirations. So we see this as an achievement. So we are also expecting other achievements in the coming years. So I think we may proceed to the next presentation.
Thank you.
Bismillah ar-Rahman ar-Rahim. I'm very glad to stand here in front of you to present this important topic, the management of esophageal cancer. So this will be my outline. The introduction of esophageal cancer, which has been mostly covered by Dr. Mohammed Bihi. And also I will share with the clinical features, investigations, and also the staging and management of the esophageal cancer. So as we know and as we are aware, esophageal cancer is one of the deadly diseases, and it has one of the poorest prognosis, like pancreatic cancer. And mostly it has two dominant histological classifications. It has been mentioned esophageal squamous cell carcinoma and adenocarcinoma. So squamous cell carcinoma is one of the commonest one over worldwide, but adenocarcinoma is currently became common in American Western countries. So squamous cell carcinoma has been measured. So it has been mentioned that there is esophageal pelt from Far East Asia as well as Afghanistan, Iran, and also India. There are specific areas that's more having esophageal cancers, and also some South Africa as well as Eastern African countries like Ethiopia, Somaliland, and Sub-Saharan Africa. They do have the cancer, esophageal cancer is becoming common. So it has been already mentioned some of the etiological factors of squamous cell carcinoma, but in our setup, tobacco smoking is too common. But also, there are our population, mostly they eat red meat, and that can maybe change into carcinogens like nitrous amines. Also, there is multiple, we use vegetables and fruits are less in our diet. So there can be like nutritional deficiencies. The other thing is mostly physical factors. It has been mentioned that thermal trauma and hot foods and drinks are common in our population. But they didn't wait till it becomes a little bit colder, but they drink the tea as well as some of the porridges. So this is a research done in Ethiopia. So what they have seen is that most of the population that this affected was males, and most from Oromia region as well as the Somali region. So both of them, they share common things. Both of them, the Oromia region, they use what's called porridge, which is very hot, semi-liquid food, and they consume it while it is too hot. While the Somalis, they also share with that porridge, but also with a hot tea. While when they finish drinking, almost the cup is almost having smoke from the heat. So I think that's one other risk factor, and most of it causes squamous cell carcinoma, but adenocarcinoma is less common to our community. So this has been already mentioned, and squamous cell carcinoma, adenocarcinoma, they're most of the risk factors. So as you see, esophageal carcinoma, there are locations. So cervical esophagus is only 8%, but it's very deadly, and it's already metastasis to the major organs like the aorta as well as the trachea, and also the vertebral body. So mostly it came with a late stage, and nobody do any surgery, but chemoradiotherapy is the one. But the most of the patients, they came with lower thoracic as well as the middle thoracic. So 60% they came with middle thoracic, and as well as the lower thoracic. So when we see what's called Stewart classification of the gastroesophageal junction tumors, class 1, it's above 1 to 5 centimeter above the gastroesophageal junction. That's class 1, and the class 2 is 2 centimeter below the gastroesophageal junction, as well as 1 centimeter to gastroesophageal junction is class 2, and the other is class 3, which is the epicenter is less than 2 centimeter to 5 centimeter below the gastroesophageal junction. So all of them, they are considered that they are gastroesophageal junction tumors, but this is mostly the tumors that correlated with adenocarcinoma, secondary to Parotis esophagitis, as well as intestinal metaplasia and dysplasia sequences. They also relate with obesity and other problems like viral infections. So when you come to the clinical features of the esophageal cancer, most of the patients, they came with dysphagia, but this dysphagia, they only came when 60% of the esophageal lumen has been infiltrated by the tumor. So it is so advanced, and it's late to come to early, because most of the patients, they didn't detect that they do have dysphagia or difficulty of swallowing. And the other thing is weight loss. So the patient is, when they develop dysphagia, they cannot feed. So what they start to do is metabolic response to starvation. So they develop to have cachexia, as well as to use the muscles and also their fat. So they lost weight around more than 20% of their body weight. They may develop adenocarcinoma secondary to some ulcerations, and also sometimes regurgitation, because there is when there is obstruction, then the patient cannot, the food cannot go down, so they regurgitate the same food that they have already taken. The other thing is when they become very advanced and the surrounding structures, the surrounding, so like recurrent laryngeal nerve when involved, the patient may develop hoarseness of the voice, and sometimes when they develop dyspnea or shortness of breath secondary to because of the phrenic nerve infiltrations, and they may have coughing and choking when they feed, secondary to tracheoesophageal fistula, which is advanced and inoperable cases, and sometimes they may develop superior vena cava syndrome. The patient may develop plethora and edema and congestion of the face, secondary to because of the infiltration of the inferior vena cava. The other is palpable supraclavicular lymphadenopathy and malignant pleural effusion, so which is too advanced. So as you can see, they came to you with this kind of cachectic and wasted patients with having low insulin level, high glucagon level, with wasting, and all the muscles, including those of the entire body muscles and fats, has gone out. So they do have also reduction of resting energy expenditure. So there are clinical classifications of grading physiologically. So grade 1, the only few people came to you with grade 1 while they are eating normally. It's only 11%, and then incidental finding like endoscopy can be identified with this. But grade 2, which they require when they are eating, they require liquids to the meals so that they can swallow. So 21%. The other is grade 3 and grade 4. So most of the patients, they came to you with stage 3 and stage 4, which is 30 to 40%, while they are unable to take solid foods, but only with a semi-liquid food, and also grade 4, which is only when they take liquids. So 70% of the patients, they came to you with this class 3 and class 4. Class 5 is unable to take liquids, but able to swallow saliva. The other is unable even to saliva, which is grade 6. So as you can see, 70% of the patients came to you with grade 3 and grade 4. So when we come to the investigations, we have basic investigations and imaging investigations. Previously, we depend on endoscopy as well as barium swallow and CT scan, but currently in the advanced they depend on endoscopic ultrasound and PET CT scan that detects as early as possible. But because these others, they didn't detect that much in esophageal cancer, but in endoscopic ultrasound, it gives you all the 4 layers that the esophagus has, although serosa is missing in the esophagus, but all the 3 and all the layers can be detected with this, and also they are good in staging of the lymph nodes. So this is what I have already discussed. So as you can see, this is our GI endoscopy. The location, it will tell you the location of the tumor from the incisors till the duodenum, and also it will tell you whether it's complete obstruction or partial obstruction, and also the extent of the lesion, whether it's 2 centimeter to 10 centimeter or the length of the lesion. So also the good thing, you can take a biopsy, but you have to take the edge of the lesion, but not the necrotic site. And also, so when they take the tissue, more than 95%, the diagnosis will be confirmed by this histology. You can see here, this is ulcerative malignant esophageal mass distal esophagus. And here, that's the barium swallow. You see multiple filling defects with polypoid lesions, and there is also a scarring and multiple polypoid lesions of mid-esophagus. And here, as you can see, this is the CT scan. So it tells you that almost the esophagus is obliterated, and more than 65%. and here is the esophagus almost occluded. So esophagus is just adjacent to the aorta. So if that fat plane has gone out, that means it is almost inoperable. So you see here the endoscopic ultrasound, which gives you all the layers, mucosa, submucosa, muscularis propria, as well as the adventitia of the esophagus. So if there is any lesion, it can detect easily. So here, there is a small lesion. So that lesion can be detected by endoscopic ultrasound, which is not available here in our setup. And the accuracy is more than 80%. So it is a golden standard of TNN staging currently in the well. And also, endoscopic ultrasound can be also resected that lesion, and sometimes even dissection can be done. So this is American Joint Committee Cancer Staging System. So as you see, the tumors can be resected till T4A. That means when the tumor invading the pleura, pericardium, or even the diaphragm can be resected. But if the tumor reaches the other adjacent organs like the aorta, the airway, or the trachea and vertebral body, it's unresectable. So the patient should be only taken chemoradiotherapy or other palliative modalities like stenting and also dilatations and also chemoradiotherapy, which may help the patient. So the treatment of esophageal cancer, we can intend as a curative or palliative. So the curative intent is unfortunate because most of the patients, they came late. So only maybe 20% came to early. So that can be, curative intent can be done, but most of the procedures is palliative. So this surgery can be open or minimal invasive endoscopic procedures. Open surgeries we will see later more. But also what we can do is chemotherapy, radiotherapy, immunotherapy, and palliative care. So the goal is to cure those with early disease, but to prolong disease survival for those who have, for example, T3 or T4, and to palliate the symptoms those who have dysphagia, which is unresectable. So for the treatment, depends on the stage. So if it's limited, if the patient has a limited disease, or if the patient has a local regional disease. If it's limited, that means if it's limited to the mucosa or submucosa or muscularis propria, it's limited and there is no means N0 or M0, whether or if it's local regional metastasis like, and I mean whether it is reached to the diaphragm or pericardium, or whether it's advanced metastatic to the bones as well as the lingual liver, and also down to the celiac lymph nodes. So also the types of the histology is also significant, whether it is squamous cell carcinoma or adenocarcinoma. So also the general fitness of the patient, whether the patient is fit or unfit for the surgery, is also important. So only 20% of esophageal cancer present early and became curable. So neoadjuvant chemotherapy, chemoradiotherapy prior to the surgery improves the survival. So aggressive chemoradiotherapy also may be used for curative therapies in patients with cervical esophagus and who have unfit for surgery, because those lesions, they immediately reach to the aorta, trachea, as well as the vertebral body. So and you cannot remove the whole trachea as well as the esophagus, so the patient may die with the morbidity and mortality. So importance of margin is, it's difficult, but it would be, there is a conflicting data of importance of the margin of status. R0 resection is very difficult, and also it increases the morbidity and mortality when you do, for example, 3-hole procedure. It's whatever you do, but still the patient may die with the morbidity and mortality, and also may develop multiple complications like fistulas as well as the anastomotic leaks, and also because you dissect more and you remove more tissues, and it takes long time So mostly what we can have a selection to proper therapy for curative and implock, but if the patient is there more than 75 and they do have dysphagia, what we can do is only palliative transhiatal esophagectomy, which is less time, and also give the patient very comfort, as well as if there is physiological fitness is low and the patient forced expiratory volume is less than 1.25 liters, because we need initially to have at least 2 liters, and ejection fraction of the cardiac is less than 40%. That patient cannot afford surgery, but we have to palliate it. And clinically, if the patient has all these features, like recurrent laryngeal nerve, Horner syndrome, persistent pain, and or paralysis of the diaphragm, we have to do just palliative. And endoscopic, if there is a transmural lymph nodes, which are more than 4 lymph nodes, only palliative surgery should be done. Intraoperatively, when you see the patient that have unresectable primary tumor, which reached the important structures and also spread to the lungs, as well as distant metastasis to the liver, and the extension through the mediastinal wall, that time you only do just a palliative surgery. Sometimes you can try curative implock resection if these are not exist. Here, this is the criteria for curative intent. So if esophagectomy can be done first when they are in the early T1 and N0, M0, T2, N0 and M0. But these others, they need to have a sandwich or neoadjuvant chemotherapy, then to do surgery later. But it's relatively contraindicated if the patient has, as I mentioned already, in advanced age and comorbidities. So criteria for unresectability is where it is one that is metastasis and also unresectable primary tumor, and when there is thoracic or abdominal esophagus, which T4 that has already reached the main and structure like aorta and cervical esophagus, because of it infiltrates the prevertebral fascia and posterior larynx, and also invasion of the membranous trachea and bilateral encasement of the neurovascular structures. It is considered as unresectable. So what the surgery we do, the choice of the surgery depends on the tumor location and length, as well as the adherence of the surrounding structures, the type and the extent of lymphadenopathy, and the conduits that you will be using to restore the GI continuity. The patient factors also is very important, and also the surgeon preference is also matters. So this is what we can do for surgery. We do these methods. We do Ivor-Lewis, transhiatal, Mark 1, and sweat procedure. Also, the anastomosis can be done in the neck as well as or in the thorax. We do also the conduits that we use. Best conduit we use is stomach. Next to that is colon. If the stomach, for example, is not exists, and jejunum. So this is also. So this is what we call it transhiatal esophagectomy. This is just a plain esophagectomy. You just have laparotomy as well as neck an opening, and then you remove and bring the up to the stomach to the thorax. This is the conduit. Is when we need to have a conduit. Most of the conduit is preferable in the left colon, but also right colon can be used. We cut, for example, if we are using right colon, we cut right colic artery, middle colic artery, and ileocolic artery. Then we depend on the left colic artery, and also we didn't interfere the Drummond arc. So we take this part and then we anastomose the esophagus, and then because of the stomach cannot reach there, sometimes when it is involved down to the fundus as well as the subcardia. So this is the Ivor-Lewis. It needs to do thoracotomy as well. So you need to have laparotomy and right thoracotomy. So the anastomosis will be in the thoracic cavity. This is what we do. But this is called transitional esophagectomy or Mark 1 esophagectomy. It's plus the left neck incision. And this is the suite procedure we do on the left side. So the complications can be conduit ischemia, anastomotic leak, as well as anastomotic stricture and chylothorax. So when the anastomosis is in the stomach and there is anastomotic conduit ischemia, mostly we just dissect it and you just open the incision of the neck. And when there is anastomotic leak, mostly it needs to heal by you insert just a stent. And when there is anastomotic stricture also, a stent is better to insert as a temporary. So this is the clinical situation is that we can have an stent. For example, if the patient has an inoperable for compassion, you have to insert an stent. And sometimes when you have a temporary measure for a malignant structure, stent is needed. And when there is a temporary intervention, for example, you plan to do when you plan to do resection and you need downstage, you need also to have a stent so that the patient have good nutrition. So this is the other palliative that we have do. So it's dilatation as well as a stent, and sometimes to do also laser photodynamic therapy. Thank you very much. Cardiovascular surgeries in our hospital or in our environment. Also, we don't have that much endoscopic ultrasounds and other investigation modalities. It's not available here in our hospital. And in the private hospital, it's too expensive to have endoscopies. And the other thing is the patients, they came very late. So here only what we do is, for example, feeding tracheostomies too, and just for feeding, but we cannot even do the palliative procedures like stents or dilatation.
Doctor, thank you, Dr. Abdullah. Next will be Dr. Andrew will demonstrate us about arthroscopy. And welcome, Doctor.
Hello, everyone. I'm Dr. Wang Yanxiang, and you can call me Andrew. I'm a general surgeon from Taipei Wanfang Hospital. Now I am a member of Taiwan Medical Mission. Today, my presenting topic is introducing laparoscopy surgery in Hargeisa Group Hospital. Because of time limitation, my topic will be short. And the history of endoscope began since the 19th century. And since endoscope developed, the laparoscope history began since 20th century. The first laparoscopy surgery is in 1933. The Dr. Fevers do laparoscopic additional lysis, and he did hemostasis. And the important surgeon, Dr. Hersi, he developed the multiple laparoscopy instrument, like he invented automatic CO2 insufflator, and he also invented multiple instruments like hook scissor, like suction irrigation system, and he also performed the first laparoscopy appendectomy in 1983. The first video guide laparoscope is invented since 1987. So after we review the history of laparoscope, we can see advanced in laparoscope, like illumination, like pneumoperitoneum. Initially, there is no pneumoperitoneum. If there is no pneumoperitoneum, the intra-abdominal cavity is very small, so surgeon can only do diagnosis. After pneumoperitoneum was invented, the abdominal cavity is increased, so surgeon can do more procedure. And we also can see the advance in optical and the lens and the television camera. So laparoscope advanced since diagnosis use to therapeutic use. First, we did laparoscope for diagnosis. Then it advanced to do benign disease surgery. Now, laparoscopy resection of malignancy is also available because the outcome is favorable as compared to open surgery. Even some selective emergent case, we still can do laparoscopy surgery. This photo show our laparoscopy in Wanfang Hospital from top to low. You can see the TV camera, and this is the photo recorder, and this is light source, and with camera system, and this is automatic CO2 insufflator, and this is the hard disk recorder. So laparoscopy laparoscopy image can be recorded. And we see the components of laparoscope. First, we usually use 0-degree laparoscope with flexible tip, and 30 degrees laparoscope is also common. We can rotate the lens, so we can see all angles of operative field. And the camera system is also advanced. Now we can see high definition imagery on the TV, and even ultra high definition and the 3D high definition is also available now. And we usually use LED as light source. This is automatic CO2 insufflator. We can adjust the speed of insufflation, and we can monitor the intra-abdominal pressure and the electrocauterization. Now we usually use the energy device like ligation, harmonic sonosearch. So electrocauterization is faster and more safe. And the such irrigation is also useful. And this is a trocar. Trocar is divided into disposable and the reuse. This one is disposable. And we have multiple working instruments for laparoscopy. The left picture shows how we did. The left picture shows the laparoscopy cholecystectomy instrument, like bowel forceps, dolphin, dissector, hook scissor, and grasper. And the other common instrument including hemoclips for small vessel ligation, and the hemolux for great vessel ligate. Left picture is hemolux. And the right picture is endo-GIA. It's used for bowel resection and anastomosis. I have some video presentation. Left image show how we set up laparoscope at the beginning of surgery. The first one is suction tube, and you can also see the ligature. And the next one is camera head of laparoscope head. And the right image show how rotating nurse help to establish laparoscopy system. The first one is light source. And the next one is CO2 insufflator. And this is electrocauterization. And this is the camera head. After connection to machine, you can see imagery from TV. And the last one is suction tube. This video shows how we do laparoscopy surgery in Wanfang Hospital. The first one is a scrubby nurse. And the next one is the surgeon. He's the important person during surgery. And the opposite side of surgeon is assistants. Assistant help to hold the camera. There are two assistants. And the anesthesia stand at the head side of the patient. So surgeon can do laparoscopy surgery with two hands. And the assistant help to control the camera to let the surgeon see the operative field. This video is one case of my laparoscopic cholecystectomy. This is one case of cholelithiasis. And we identify the CBD first. And this is chiral triangle. We start surgery 6 chiral triangle at chiral triangle. We use hook to dissect peritoneum. And the tubular structure is city duct because its connection to CBD, city duct. And we use ICG fluorescence to confirm that this is definitely CBD, and this is city duct. After confirm this is city duct, we will use endoclip for ligation of city duct. Usually we use 2 clips at the stump site and 1 clip at the resection site. After ligation, we use scissor for cutting the city duct. And the city artery will be dissected out from peritoneum. This is city artery, and we also use hemoclip for ligation. So after ligation, we use a scissor to cut the city artery. After ligation of city duct and the city artery, we dissect gallbladder and liver bed by hook. After dissecting from gallbladder, we use glove mat and bag and to remove the specimen. So you can see the laparoscopy cholecystectomy and the laparotomy and the open cholecystectomy. You can see the operated scar is quite different, the size. So inclusion, why we need laparoscopy in Hargeisa Group Hospital, because laparoscopy surgery can do many kinds of surgery, and many surgical departments like our general surgery, GYN, and urology, and even chest surgeon, we all use laparoscopy equipment to do surgery for benign disease, selective emergent disease, and even malignant disease like colon cancer, pancreatic cancer, esophageal cancer. And the laparoscopy surgery is minimum invasive surgery. It means the operative wound is smaller size. So patient have less wound pain. So he can recover soon. and the most important, the shorter hospital day, shorter hospital stays. I came here since 1 month ago, and I observed that most Hargeisa Group hospital surgeons had already learned laparoscopy skills in other countries, like Ethiopia. So I think laparoscopy surgery is not a completely new skill for them. And they also have mature laparoscopy skill. It's important because when we do laparoscopy surgery, sometimes severe complication will occur, like massive bleeding. When severe complication occurs, we will do conversion to laparotomy. So mature laparotomy skills is also very important for laparoscopy surgery. And last, I think the most Hargeisa people visited public hospital. Laparoscopy surgery can only be performed in private hospital because they have more resources, but the cost is also very expensive. If Hargeisa Group Hospital can do laparoscopy surgery, I think more and more people have the chance to receive the laparoscopy surgery. So finally, our Taiwan Medical Teaching and the Taipei Wanfang Hospital, we established the training program. We have some laparoscopy instrument already, like this one. This is dolphin dissector, yeah. And we have the instrument, and we will introduce the laparoscopy simulator first for residents and the interns. If laparoscopy surgery can be performed in Hargeisa Group Hospital, yeah, we have the chance to do, our Taiwan Medical Mission surgeon can work with surgeon together. We can do surgery together. And finally, we have visiting scholarship for training in Taiwan. So if some surgeon wish to learn advanced laparoscopy skills, they have chance to Taipei Wanfang Hospital for training. So that's my topic. Thank you, everyone.
Thank you, Doctor. Thank you. Our next presenter, Dr. Ahmed Saeed.
Hi, everybody. I was given a small talk about orthopedic resident program in Hargeisa Group Hospital and University of Hargeisa. So my name is Dr. Ahmed Saeed. I'm head of orthopedic department. So I will try to summarize it. This orthopedic department is staff, and in 5 years back, there was only 2 doctors at the department, me and Abdurrashid. When we arrived, we saw that there is a lot of things, and the workload is very high. So at that time, we decided to establish a resident program which could help us. Then now we are 5 orthopedic surgeons. We run a resident program, and there is 5 residents and 2 other orthopedic practitioners in our department. We have an orthopedic department office, and it was helped and furnished by Taiwan Medical Mission Group. Thank you, especially Dr. Tegas. And we have, they helped us about the furnishment, tables, chairs, bookshelves, restrooms, and everything. So the reason I was given this small talk was because we are good friends with Taiwan Medical Mission Group in Somaliland. So in orthopedic activities we do, it's all about related to 2 things. One is related about the patient care. So like other doctors, we run OBD, operation theater, war round duties. And the other thing is we had in our hands some orthopedic programs like resident program. There is what we call CNL program, which I will show you at the end. And we do some annual health campaign programs. When it comes to resident program, it is a 4 years duration program. And we use what we call trainee-centered approach. That means we put all the responsibilities to the residents. They read themselves, they prepare the cases, they participate in operations, they do post-op care about the patients and everything. So we supported them and they prepare themselves. Then we supervise. The program content is, or the program mainly contains three things. One is about we teach them orthopedic knowledge. The other thing is medical ethics. We should teach them the hierarchy and responsibilities. And the other thing is clinical research. So if a resident will do one research at the end of each year, then after that they can graduate. We do some assessment of our resident. So that assessment always covers about their knowledge, skills, their attitude and performance. We have some kind of forms. So we fill these forms from operation theater, OPD, emergency, and even our nurses participate about their assessment. So at the end of each year, we make them an exam so we can assist them. So this is yearly or every 3 months we make an assessment for our resident. We assess about their attitude, their improvement or clinical skill, how they diagnose the patients, how they do preparations, post-op and everything. So always every 3 months we came together all the seniors at the department, so we evaluate them. So every morning at the Hersi Group Hospital, orthopedic department, we have a morning session. So they come up with every resident who was on duty, like on that day, bring about his morning. In the morning, they bring about their duty and cases they have seen. So they write. They write at this form. Then we sign it and we collect it and we put on the file. So for the last year, like the last 12 months, morning sessions and attendance and everything about their assessment is on the record and it's available. So in every Thursday or weekend, they do one major seminar. So the seminar is one of the assessments we do. So they prepare major seminar and they present, we participate, and we evaluate. They had a logbook. So on that logbook, they write every case they see, they participate, they assist, or they perform. So we sign it at the end of the day. So our residents, each year, we need to have a new agreement, always, and contract. They should have to bring a new sponsorship letter if resident is either from hospital or university. So we don't want to lose about any resident. So in that case, if they don't bring any about sponsorship letter, we can solve it and we can ask the reason. We need to have pre-op daily, post-op in every cases we operate. At the end of the week, we discuss. And we have some formal lectures at each week. We do teaching workaround, case presentation at each week, journal club. Still we didn't start it, but soon we will start it. And we always appoint one of our residents to relate about the departments like radiology, oncology, and stuff like that. So they need some of educational resources. Some of them we had, some of them we don't have it. Like we don't have any We don't have a department library, so they can refer it. We don't have any internet access library or e-literature. We don't have it. We get youth room like last months. We have BOB room, minor room, OT, all this stuff are available. But the library and e-library is not available. So for 2003, January to December, in OBD, we did 9,412 cases. We operated 706 cases. And due to consultation, we did 670 cases. Most non-operative cases, we didn't have any data because this is done by an orthopedic technician, and there is no data on it, but we will find next year. We operated 706 cases last year, and that's about their data. The other thing we had is nail program. Nail is like a kind of intramedullary nail, which is donated by Fracture Care International, which is humanitarian international NGO based on USA. So they gave us about nail, which is a kind of an instrument or intramedullary nail. So they give low-income countries. They give like these countries, Angola, Botswana. They give more countries. For the last 5 years when we arrived, we requested them to give us about the nail. So they started in Somaliland 4 years back. And first place was Hersi Grove Hospital, then Ismail Specialty Hospital, then Manhal Specialty Hospital, Borome Specialty Hospital, and now they are going to offer in Borough Regional Hospital. Intramedullary nail is like this patient. He have a gunshot injury, so he have a femur fracture with a bullet fragment. We operated, we put intramedullary nail. This is called a nail. So the patient is able to sit back, walk, and go back to his work. So it's like kind of load sharing. If you operate the patient, he can walk next day. It's another patient. He have a bullet injury in the femur. Bullet femur in the femur. Then we put intramedullary nail. Then he works 45 days. This is another case. We have a comminuted femur fracture. There's all fragments there's a lot of fragments of his femur. Then we bring back his bones together. As you see, this is a small part, this is a small part, this is another part, this is another part. So finally, this is the result. We put the same nail. He starts working after 1 week, and he's fine, finally. Within 45 days, he can go home. So about this nail program, we put into form a database, which is online. So we fill bureau up and post up 45 days and 90 days. This is how we do it. We need to put the data in 45 days. And then after 90 days, the problem is like some people are from far regions, so they will disappear after they came. It's difficult for them to come back. And this needs higher internet speed and good quality camera. But we use our phones, and we have a PC, but we use our phones. So when you put the data into the program, and there is a percent. If it's like less than 30%, they will not replace for you the nail. They gave us the nails whenever we put the system, and the fellow is like more than 30%. They will give us the nails. If the percentage of follow-up is less than 30, they will stop it from donating. So this is like, most of the time it is like more than 70, and it's quite good. We did some orthopedic guidelines we had, like ATLS, open fracture management guideline. We did some vascular injury management guideline, and we list our emergency cases, which we can do overnight. Thank you.
last year, 2023, because because Taiwan Medical Mission is here for the OT, we will some investment, CR or some traction table. So what different before and after for the surgery? Thank you.
I was planning to bring that initially in the OT setup. We don't have a traction table. We don't have a CM. The instrument is and settings were not enough. So we came to Taiwan Medical Mission and we had some requests. So they helped us about bringing settings and implants, and it became like easy for us to do some of the cases. And there was no CM, and we were not able to do intra-tract fractures, intra-articular fractures, and some fractures which need CM, we were not able to do in Hargeisa Grove Hospital. So after we get the CM, now we do everything. And we have a traction table, so we do intra-tract fracture. Now we have, what's missing only is about the arthroscopy. We have arthroscopy machine, 2 arthroscopy machine, which is fully functional. And there was a small missing some of the staff, but Taiwan Medical Mission also helped us about that. Now what's missing is about only training. So the doctors are here, and we did some training from Turkey, India, but still we need some. And since the machine and arthroscopic machine and all the staff is available, if we get that one once again from Taiwan Medical Mission Group, our friends, it will be very nice. So thank you very much. In orthopedic department, we couldn't stand alone without Taiwan Medical Mission Group. Thank you very much.
Thank you, Doctor, our head department. Our next speaker, Dr. Yu Ping.
Okay, thank you for your introduction. And well, thank you for all comes here. I think now it's close to lunch, so everyone may be hungry. So well, I will try to face my presentation and focus on what we can collaborate on the training program between your residency training and our residency training. So this is my topic. It's an orthopedic training collaboration between both hospitals. Well, before I go through my presentation, I want to introduce our institution because my hospital, I come from Wanfang Hospital. It's a medical center in Taipei, and we belong to the Taipei Medical University. We are one of the Taipei Medical University affiliate hospital. And this is my department. We have 5 surgeons, and 2 is associate professor, and 2 assistant professor, and another 4 attending physician, and we have 3 residents. And also we have 3 nurse, a practitioner, and 2 research assistants. Well, so this is the part I want to introduce what we have and what's special in our department. I will focus on the 3 parts. The first part is what surgical field we have, and also our clinical care and research about our department. Okay, as for our specialty, I think the philosophy of our department is that less is more. What does that mean? Because if later I will demonstrate a lot of case. That is, we try to cause less invasive, to cause less damage to soft tissue, and get more quality and get better outcome for the patients. So less is more is the philosophy in our department. Well, as for trauma, I think you still have a lot of trauma cases here, but in our department, we try to make smaller or even tiny wounds to get the fracture get fixed. For example, this is quite common situation in our institution. This is a distal radius fracture, which belongs to the older population and get the low-end trauma. So you can see here, it's a distal radius and distal ulnar fracture. It's a comminuted. And we can do very tiny wound. This is a double plate fixation for this part. We only use this wound. This incision wound is only 2 centimeters. And we can get the reduction just like this. And also a minimal invasive proximal humerus fixation, just like this. We only have, if you use a traditional way, you have to create even more than 10 centimeters wound. That's a pectoral approach. But however, using this immuno-invasive surgery, we just can only close 2 small wounds to create or to fix that fracture. And not to mention the proximal femur, the hip fracture is also one of our specialty. It's quite common surgery in our hospital anyway. So we can also do that fixation, only use a very tiny wound. As for the spine surgery, I think a few months ago, one of our director is a Professor Guo Yijie, and come here, and he also demonstrated some surgical technique to do the spinal fixation. Well, it's quite common in our hospital. And as for our daily practice, well, we also try to do that using the minimal invasive surgery. So this is a traditional way. If we want to fix that, we have to create a lateral wound. It's a huge wound, and we have to sacrifice the muscle, spinal muscle, and that is the reason why the patient will feel weakness, a fracture after that surgery, because we create a lot of wound and also do a lot of damage to soft tissue, including the paraspinal muscle. So right now, we have a special device. We can do that, only use 2 small wounds, and we can get the similar result. And also, we can even using this wound less than 2 centimeters, we can also get 4 segment fixation. This is a minimal invasive surgery. However, right now, we have another trend. We do that using endoscopic. This is a precutaneous endoscopic lumbar discectomy. We only use a really tiny wound, maybe less than 1 centimeter, and we just get through that lesion part using the scope. And then we just remove that ruptured disc. And patient get recovered very fast. They can get discharged the day after surgery and just walk out. So this is quite common surgery in our hospital. This is a pan-percutaneous endoscopic lumbar discectomy. It's only especially one part of our specialty in our hospital. And as for sports, well, belongs to a sports surgery anyway. This is one of my specialty. I do a lot of tendon repair surgery, and this technique, I learned from Professor Nicola Mafuri, who is the editor of the Journal of Orthopedic Surgery and Research, and is a big professor in Italy and England. I learned from him, and he taught me that if we want to do, for example, this is an Achilles tendon repair. And we usually create a great wound to repair tightly for the Achilles tendon. But however, right now, I only use this immuno-invasive surgery, only use 7 tiny wounds. I can do the same thing, and even the reconstruction. This is a traditional way. If you want to do the reconstruction, we have to create a large wound and use fascia tendon. And that will cause very high infection rate, maybe up to 30%. And even the wound breakage. However, right now I can still use a small wound to do the tendon reconstruction. This is another very fancy surgery technique. And also, I did a lot of hand and foot arthroscope surgery. This is a TFCC. It's a triangular fibrocartilage ligament complex, just over here. Maybe someone know that disease. It's quite common in our country because that may be caused by a stressful twist of your wrist, and that will cause this part pain, the dysarthritis pain. So when the patient try to rotate their wrist, they will feel pain, feel discomfort, and for some part of this patient may get this TFCC tear. So I can also do that just using the arthroscope, only 2 small wounds using arthroscope to repair the TFCC. And that can also get a very good quality and good a cure of that kind of disease. And this is another example. We can do the arthroscopic assisted fixation for distal disc fracture, arthroscopic assisted fixation for scaphoid fracture. That only causes a very tiny wound. Totally different from traditional way. And also, this is another common surgery in our hospital. It's a holosparcus correction. We only can use a small wound to correct the deformity of their foot. And another part, this is another very famous professor who have learned from Dr. Berha, who is a big, famous professor in America. And he learned from him. So he just focused on this, doing the arthroscopic surgery for rotator cuff repair. I think maybe in this country, you still have a lot of patients have that problem, have a rotator cuff injury. And we usually do the open repair. But however, it's quite common in our country to do that using arthroscope. And that can also get an even more better outcome when compared with a traditional open repair. This is another sample. We use the arthroscope to do, this is an ankle OCD, you can see here. This is a tibia platform bony defect. And do this using the posterior ankle scope to get this defect and infill with some bone substitute and some special material to cover this defect. And the patient can get a very good outcome. And I also do that for elbow. This is a special case. This is a female, a woman, who complained that his elbow cannot fully extend just because they have a chronic elbow pain. And this is I doing that surgery. You can see it is a lot of hypertrophy of synovium. And we can only also do that using the arthroscope to debride all of this inflamed tissue. And after surgery, that is maybe 1 week after surgery, she can get the full extent of their elbow. And also we'll do this MPFL reconstruction. And also my another specialty is anterior cruciate ligament reconstruction. Okay, another one, this is joint replacement. Well, this is quite a big part in our department. We have a different way to doing the joint replacement. That's the knee replacement. This is Professor Ho Wei Bin. Is also one of my teachers. He is very good at this. We have done a lot of surgery for the knee replacement and also a total hip replacement. I think that maybe in this hospital, just I mentioned, maybe we don't have that instrument, but maybe we will work on this to try to get some resource to get our domestic med processed here. But anyway, this is another way. If it's a sample, if a patient gets a total knee infection, we invent a new technique to treat second stage, two-stage treat the infected total knee and get a very good clinical result. Okay, that's the special technique. Not for all, but I just mentioned some very fancy, very interesting part we have, but still have a lot of part in our hospital. So later I will introduce what kind of research and quality program we have. Well, because Wanfang Hospital, located in Taipei City, we have a lot of older residents around our hospital. So we have a lot of patients, or we have a lot of hip fracture in our hospital. In our hospital, every year, we have around 200 patients receive hip fracture surgery in our hospital. So it's quite common. Maybe 1.5 or every 1.5, 1.10, we have one patient receive hip fracture surgery. And we found that, because we always focus on this part, because we found that this patient always have a very big outcome. For example, in our Taiwan clinical register data, the 1 year mortality rate for this hip fracture patient, even receive a surgery, that would be up to 60% after surgery within 1 year. And also, for majority of these patients may turn into disability after hip fracture surgery. Or maybe they will, in the near future, they will get second time fracture and return back to our hospital to receive another surgery and then turn into be disability or death. So this is a vicious cycle of a geriatric hip fracture. So in the hospital, we try to collaborate with another program. This is a fracture liaison survey. I don't know you know this program. This program is proposed by the International Orthopedic Foundation. And the spirit of this program is that we know this patient, especially for hip fracture patient, they are under very high risk for future second fracture or future fracture. So if that is the case, we can treat layer underlying disease that is osteoporosis. And this part is always be ignored by the clinician. So once we get the patient with a hip fracture, we can do more extensive and comprehensive exam for their bone quality or the risk of a falling accident. And then we can promptly give them some treatment, for example, the anti-osteoporosis medication. So that can break the vicious cycle and prevent them to get a secondary or second time fracture. So this is a fracture liaison service. Well, so this is our team. We organize a team. We call it our One Farm Fracture Avengers. And we did that. This is our project and a flowchart of a patient. Once they get a fracture, they will then receive the further comprehensive exam. For example, the FRAX assessment, the bone marrow density, and even the risk of falling. And also, the important part is that we try to organize and work and establish a hip fracture registry. We just collect all of the patient data from this patient. And until right now, it's about 5 years of running. We already have almost 1,000 patients who have been comprehensive recorded in our clinical registry. And we focus on the patient outcome and also focus on the effect of osteoporosis and sarcopenia on this patient, and also focus on the complication of a hip fracture surgery and the function and the quality of life. And this is a result we apply the fracture liaison service among our patients. See here, before we apply the fracture liaison service and can compare with the patient receive a fracture liaison service, see here, the osteoporosis treatment after hip fracture can be increased from the 22% up to the 72%. And also, we can effectively reduce the refracture rate from the around 50% to the 5%. And also the mortality, although that not reach significance, you can see here, before we apply the fracture liaison service, the 1 year mortality rate is 18%. But however, after they receive this fracture liaison service, we reduce the mortality rate within 1 year, just less than, around 12%. So this part, we also get some paper published in the article, just mention what we've done, what we apply this program to this patient. I think this is a good program. Maybe that can also be applied to your institution. So I think this is also a very important part to improve the quality of care for these fracture patients. And then this is our honor. We have been we gathered the golden prize from the IOF for this program, and also win our National Quality Award to care this hip fracture patient. And then as for the training program, I think this is the most part of my presentation here. I'm going to say that, well, thanks for this program from our collaboration. Well, we can offer 3 months hands-on training course for your residents. So I think this is a very good chance you can come to our hospital to learn from some skill from us, especially for this esophageal technique. And also, you can also learn lots of surgical technique, including the spinal fixation, including the sports medicine, and including the joint replacement. Anything, if you are interested, you are welcome. And also, we will try to collaborate with you on this research work and to establish your own data registry. I think you should focus on what kind of disease is your most common disease. Maybe we can organize a registry and focus on the trauma. I think that would be very interesting. You can have your own data registry, and that can help you to get a lot of paper published. And then we can also have maybe monthly remote conference, just one web-based conference. We can discuss with you, department, on special difficult case and share our experiences with you. And then this is I think it's a good chance to have an international collaboration. And then good news is that yesterday, thank you for Dr. Hassan to show me your facility, in your surgical room, I found that, well, you are so rich because you have a 2 device of oscilloscope. 2. And although less instrument, maybe we can still have some chance to get more new instrument. But right now, the instrument you have, it's enough. It can be, right now, you can do almost all of the oscilloscope surgery for the knee. Only use that instrument. So the only thing you are lacking is that you just lack of one person or one surgeon who is good at doing the oscilloscope surgery. So I think maybe we can collaborate on this. So the next step is that maybe we can help you to organize or to establish the Hargeisa Oscilloscope Center. Just focus on this special case using your own device, this oscilloscope, and we help you to train the surgeon to do that surgery. This is my presentation, and thank you for your listening. And anyway, remember that less is more. It's our philosophy. Thank you.
How are everyone? How are you? Today we're talking about falls. Falls is a public health threat that we don't emphasize. Doctor, you just discussed it. They have a lot of programs regarding hip fractures, prevention of hip fractures, at the same time post-fracture care. But we don't have that. We only treat fractures, especially the hip fractures, but we don't have any program at all. So today we'll talk about the falls, the impact they have, especially the adult falls, the impact they have, what causes, and what we can do to prevent these fractures. Next slide. Okay. Next one. Sorry. So the world population is like 7.9 billion, and 1 billion of them is above 65 years. The fall rate of African adults is 24.2%. Worldwide, it goes up to 34%. It means at least there is one fall in every 5 old patients. The impact falls could be like simple bruises or sprain, and it could be fatal, like fractures and hip fractures. Sometimes it's like head injury and trauma. It results in disability, or the adult patient becomes dependent on the children or family members. They become disabled. It also has psychological impact, because even if the old patient has an injury, falls down and has a minor bruise, they will be fearful. They will be afraid to fall again, and they will be bedridden. So you will see like an old person who is at the bed, who doesn't want to walk out because that person is afraid to have a fall again. In USA, it's like 37% of patients who had a fall before are afraid to walk again. Becoming bedridden makes them weak, and they become like they lose the muscle mass, they lose balance, and it also increases the risk of falls. It results in hospitalization with acquired pneumonia and all this. It has financial impact. Sometimes they have bed sores, and it takes like months to do something about that. When it comes to hip fractures, they have high mortality. Even if you do surgery, the aim is to do surgery within 24 to 48 hours. But here, sometimes patients come like after 3 or 5 days because they don't know the risk of having DVT or complications. Sometimes they are stuck at home because of financial reasons. And even patients that we operate or taken care of, the mortality rate is 10% within 30 days. 21.5% die within 6 months. Even some studies show it's 50%. So within a year to 3 years, around 50% of them will die. And within 9 years, 79% of them die. So it's like high mortality. So what causes falls? One is the illnesses, physical health issues. Patients may have like diabetes. They may have like knee or hip osteoarthritis, and because of this pain, they will have less walking and they become weaker. Sometimes medications that doctors provide, especially the polypharma, when patients are taking 3 or 4 drugs together. They take antihypertensive drugs and some cardiac medications, neurological medications. So it looks, it's not, all patients with falls are not taken, are not dealt with by all the doctors, like the cardiac, neurology, orthopedic. It's kind of, the patients should be treated as a whole, and all doctors must be united to do something about it. Because you may give medication, and if the patient is not told that this medication will create some dizziness, and some of the medications they have to take when they are on bed only. So they have to finish their urination and all this. Once they go to the bed, they will take this medication. Otherwise, if they take this medication and go out to have a shower or they go to the toilet, they may fall down and cause these issues. The other thing is environmental hazards. The most common is stairs. So once our elder people are above 60, we should have like flat and avoid any stairs. Rags, this is very common. Majority of the people, they will have slippery rags. This is very common in our homes. It's right here. Yeah, so this is also very common. So we have to tell all our old patients to avoid these rags, slippery floors, these cables and all this. Medications, more than 4 medications also increases the risk of falls to 75%. Yeah, if patient is taking like 4 medications, they have 75% risk of falling down. So what we can do is to prevent. That's number 1, to train the pharmacists on when to take medications and how to use them and all that. To unite all the medical doctors. We have to do also eye checkups for our patients, because once the vision is decreased, they will not even see if there is water at the ground or cables or all this. And combined care after falls. So, for example, there should be a total combined care for these patients. Once they have hip fractures, it has to be taken seriously, especially the nurses, to prevent the bed sores, cardiac team to facilitate the echo and brain aesthetic evaluation earlier so that the patients are operated within 24 hours. This is very important to have grab bars. You can see like a 60-year-old male who is having a shower like this at home. So there must be a chair at home with grab bars. For all, if your mother or father is above 60, you must have a chair and a grab bar. It's very important. The second thing is non-sleep shower mats. So you have to put mats on the showers. Other thing is lighting. There should be adequate lighting so that they can see. The other most important thing is the kind of shoes. So we have to avoid using socks, only socks. Sometimes old people, they don't like the cold weather, so they use socks. And when you wear socks, it's high risk. So every time they must have their tight shoes, well-fitting shoes, even at their bed, not only outside. And we avoid slip-ons, dacska iyo waxaa maaragta iyo sandalka waa in waalidka laga ilaaliyo. Frequent eye checkups and regular exercise to do the balance and strengthening. Sometimes we have patients at the hospital admitted for any other cause, so we have to assess the risk of falls, modify the environment just like we do at home. We have to tell our cleaners on when to, when they do the cleaning the floor, they must have proper timing for that also. Educate the family, staff training, and review and optimize medications. So thank you so much.
You do a form. It's an assessment form. So you see if the patient how is his mobility, if he's on any medication that can alter his level of consciousness and balance, and you see if he's confused. All of these things will give him a score, and then when you add them up, you know this patient needs side rails, this needs the bed to be to the wall, this needs an attendance all the time. So that will guide you. If you have that form, it doesn't take 2 minutes to do it. And every shift you will know who's your high risk and who is your low risk.
For our closing remark by our deputy.
I think before I close and give my closing remarks, one thing I would like to highlight is the collaboration that we need regarding the trauma care and trauma registry system development. Hargeisa Group Hospital, as I said earlier, we have now started with ICDF Hospital Information System, which is currently working on the outpatient department and the emergency department. But what I'm requesting from Dr. Yupin and my hospital orthopedic department head to collaborate how to create this registry for our hospital, particularly regarding the trauma, which is a burden, which is one of the leading cause of death in Somaliland. So that's one thing, and I hope that you and Dr. Ahmed, Dr. Abdirashid will work together to make a progress on that manner. I think it would be better for Dr. Superintendent Dr. Che to give his closing remarks. We have said many things so far, but I think this is should be something continuous that we do it every year for the coming years. And I'm glad to hear that our junior doctorate residents and also specialists are welcome to come to Wanfan Hospital to do hands-on training, which I hope that we will make use of the opportunity. And thank you very much. We are happy to have you here once again, and thank you very much.
Thank you. On behalf of our Superintendent, Dr. Liu, I would like to thank all of you for attending today's activity. Thank you for staying to the end, and also thank you for your active participations. This highlight that a great interest on the collaboration between your hospital and the Wanfang Hospital. And also, I can see that there are several young clinicians with lots of potential. So we look forward to our continued collaboration after this meeting. Thank you.